event. We have changed the venue and site has been changed. So the beauty of Bhopal is actually shrouding around the academics now, and our guest speakers are also very happy the way Bhopal is at the best. So let's show our academic best to them. So we have got two revered speakers. They are from uh, the best in the field. Professor Dr. D.C. Sharma sir is like a person, mentor, and he has been professor and head of endocrinology at R&T Medical College, Udaipur. Sir is a great musician, and the music of hormones also he is mastering, and the way he puts up things. So please feel free in between. The beauty of masterclass is that whenever you feel, you can ask anything, and that is how the story of masterclass has been. And we have got so Dr. Goswami has also come to us, and I've been listening him uh, in the past, and he's a very erudite speaker, and he hails from Bengal, and you all know that Bengal is known for, and the way they have put up, and a master speaker, faculty at Department of Endocrinology, NRS Medical College, Kolkata. And he's a visiting consultant to many of the topmost hospitals of Bengal, and around 105 publication and lots of awards and facilitations. And the way he speaks, so take the opportunity. You can ask the best, any kind of queries you can have. So that is how the beauty of masterclass goes. So we'll like to have a very interactive session. So to start with, I'm keeping no frills attached. Straight away, I'll go for the inaugural lecture. Next, मेरा लगा. So I've been now my task is for the setting of the stage. Insulin in 2026. What's new in the evolving landscape of diabetes care? Whenever we keep a lecture on insulin, most of the times as an economist, हमें लगता है कि यार अब क्या बोलें? What else is left? It is very difficult to take a lecture on insulin because insulin. But when it comes to physicians, when it comes to the other fraternity, people are very much open. यार insulin पे तो जरूर आएंगे. So this is how the story is. So why are we talking about insulin again? Despite major advances in diabetes therapeutics, insulin remains essential for millions of people worldwide. More than 530 million adults worldwide live with diabetes. Approximately 1 in 3 individuals with type 2 diabetes will eventually require insulin. Nearly all people with type 1 diabetes depend on lifelong insulin, and insulin remains the most effective glucose-lowering therapy available. However, many eligible patients experience delays in insulin initiation, and whenever you write insulin, they will run away. So we have got erudite speakers and masters in endocrine field. Ask them how they motivate their patient for insulin therapy. Still, still insulin therapy is something which is insulin therapy is something which is very important and very difficult to start with. Common barriers like fear of injection, fear of hypoglycemia. So there are lots of misconceptions, clinical inertia, again limited diabetic education. Still, whenever I am starting insulin, I'm spending around 15-20 minutes. यार लगता है कि चार patient और देख लेते हैं. That kind of thing is always there in a clinical practitioner because if there are people waiting in the OPD, आपको ऐसा लगता है यार ये patient कम आए तो अच्छा है. But dear friends, we will have to give time. They are the ones who need you most. This is how we were talking about type 1 diabetes also just few minutes back. The patient barriers, physician barriers तो मैंने आपको बता ही दिया. Patient barrier तो ऐसा होता है कि they just don't want insulin. साहब 4 गोली और लिख दो आप. So that has led to polypharmacy. That has led to irrational combination. I am seeing prescriptions of glimepiride, 16 milligram glimepiride. हमने कहा हमने बुक में तो 4 milligram से ज़्यादा तो पढ़ा था कि the first dose effect चला जाता है. First dose effect का मतलब है कि the moment you will increase the dose, the effect of the drug also should go up. but that is not there after 4 milligram. But I'm seeing prescriptions of 16 milligram glimepiride. That is something which I thought ki master classes should be done every month. This is something which is the requirement and need of an hour. And I also learn a lot from master classes. So the evolution of insulin, as you all know, we have been seeing such kind of slides. 1921 that led to the discovery of insulin. It was Benting and Best. So you know, and till then, lots of water has flown under the bridge. And we have got basal insulins. Future may, very soon, they are going to launch once weekly insulin also. So I'll not talk much about it, but that is something which demands a separate master class. Why does insulin still matter in 2026? Insulin remains the most potent glucose lowering therapy. The clinical situation like type 2 diabetes, we don't have any other option. Ketoacidosis, that is something which should be dealt with insulin. And pregnancy, uncontrolled diabetes, acute illnesses and surgeries, steroid-induced hyperglycemia. So modern therapies have transformed type 2 diabetes care, offering weight loss, cardiovascular protection and renal benefits. However, none can replace insulin when endogenous secretion becomes critically important. And if the endogenous secretion is impaired, rather than viewing insulin as a competitor to incretin therapies, we should see it as an essential partner and comprehensive diabetes management. So there are landmark trials. DCCT, सबको मालूम होना चाहिए. It was a trial of type 1 diabetes. Followed by this DCCT was again इनका 10 years का extension trial भी है. We have learned a lot about all of your microvascular complications have something which has come from DCCT. UKPD is the legendary trial. Devote, Switch, Bright, Conclude. So we should know at least about DCCT and UKPDs because these are the relics which are going to stay with us. These are the milestones which are going to stay with us whenever we'll talk about insulin. So ADA 2026 standards of care, what's new in the insulin management? Every year they come with some kind of new recommendations. So insulin management should no longer follow a one-size-fits-all approach. This is a statement which they have given. Age and duration of diabetes, risk of hypoglycemia, lifestyle, meal patterns, use of glucose monitoring technology. It is making a huge difference in our prescriptions now. This shift helps patients achieve better blood glucose control with fewer side effects. Key updates in insulin management ADA 2026. Let's see what are those updates. Early and timely insulin initiation. According to ADA 2026, insulin management should begin earlier in patients who have persistently high blood sugar, despite oral medications. But what we are doing most of the times, our patients, they don't want insulin. They're on multiple combinations. But that is also justified if the patient is not moribund, he's ambulatory, he's doing well, digestion is proper, and the sugars are well controlled. So insulin often delayed until failure of multiple oral agents. That is true. Earlier, individualized insulin initiation when clinically indicated, avoiding therapeutic inertia. That inertia is there. So the latest guidelines say कि आप जल्दी चालू करो. HbA1c was the major trigger, greater emphasis on symptoms, degree of hyperglycemia, catabolic features, and patient phenotype, rather than HbA1c alone. So apart from HbA1c, if the patient is lean and thin, cacaxic, and you over the top of it, you are offering him an SGLT2 inhibitor, you know what it will do. बाहर से ही दिख जाता है पेशेंट का इंसुलिन आपको इंसुलिन पेशेंट बताएगा लेन थिन कैकेक्सिक पेशेंट मतलब इंसुलोपीनिक पेशेंट द चांसेस आर हाई आप कीटोन्स करोगे तो हो सकता है वो ट्रेसेस में भी मिले आपको So insulin considered last line basically, insulin should be viewed as one component of individualized diabetes management, often used alongside the GLP analog receptor analogs, GIP, GLP-1 receptor agonists, and SGLT2 inhibitors. Simplified basal insulin management. Basal insulin remains the foundation of insulin management for many patients with type 2 diabetes. The ADA encourages simple patient-friendly basal insulin regimes. What this 2026 recommendation are, start with once daily basal insulin for most people with type 2 diabetes. But this has been delayed now just because of the newer medicines. They are more potent. We have got medicines like SGLT2 inhibitors. We have got medicines, DP4 inhibitors. And to be top of it, this imiglamin is also doing well. Sometimes, whenever a patient needs a basal insulin and he is very much wary about it, no, sir, I don't want insulin. I start the semaglutide. 1000 SR. Sometimes it works like basal insulin, and the response is good with respect to fasting. So this is how we are actually optimizing our therapy nowadays. But somehow, somewhere, there are some areas which are left out. What this ADA paper is actually pointing out. If the patient is lean, thin, cachexic, he has got multiple comorbidities. This practice of starting more and more drug, sometimes it may harm your patient. So regularly evaluate for over-basalization, fasting hypoglycemia, and excessive basal doses. These are the things which are to be done. The guideline also emphasizes reducing insulin intensity when hypoglycemia occurs, frailty develops, treatment burden outweighs benefit, and glycemic goal changes. The stronger role of continuous glucose monitoring, this is again every now and then. डॉक्टर साहब मैंने तो ये चिप लगा लिया है, मैं तो देखती रहती हूँ बस शुगर. वैसे आप बोलो कि चार्ट दिखाओ तो चार्ट उनके पास होता नहीं. बिजी प्रैक्टिस में डॉक्टर भी बेचारा बहुत तकलीफ में आ जाता है. अब वो मोबाइल में सारी चीज़ें खुलती नहीं हैं CGM की. फिर आपको लगता है कि एंड दे बिकम वेरी स्मार्ट. तो हमारे जो रिस्पॉन्सिबिलिटीज़ हैं CGM के कारण और बढ़ने वाली हैं. The morbidity is going to be very high because it is very difficult to tell a patient कि even in the best control state 24/7 में there are few values which are higher, and we are not supposed to cater those values because we are talking about time in range. So 70 to 75% of the times the sugar should be normal. But these modalities are very good to detect unreported hypoglycemias, which are rare. But nowadays, what is happening is the pharma is promoting this kind of modality. So every now and then you will come across कि डॉक्टर साहब मैंने तो चिप लगाया हुआ है, मैं चार्ट वट नहीं बनाती, आप ये देख लो. Sometimes there is a delay. Yesterday only there was a lady who was the sugar value was 224. बोला डॉक्टर साहब मेरा चिप तो 135 बता रहा है. मैंने कहा अभी 45 मिनट बाद बताएगा वो. So this is how the scenario is. This is how there are lots of newer challenges which are coming up in clinical practice. So at diagnosis and throughout care for people using insulin, for individuals with using therapies that increase hypoglycemia risk, CGM is indicated. Whenever CGM data can improve diabetes management. Newer emphasis on CGM should continue long term as discontinuation may reverse improvements in HbA1c. But the problem is that chip is costing you 5,000 rupees for 14 days. That should be brought down. Newer ones are coming. I'm hopeful in the years to come. The moment it will reach around 500 rupees a chip, I'll be giving it to most of my patients. That is true. So for HbA1c to CGM, a paradigm shift, this is true. Limitations of HbA1c, definitely we know about. Average glucose only does not reflect glycemic variability. This is hypoglycemia, influenced by anemia, CKD, hemoglobinopathies, and altered red cells. What CGM adds is time in range 70 to 180. That is something. I think it is more of a figure for pharma industry rather than for us. Because in classical teaching, we were not very much inclined to that kind of strict control, but there are studies now. So my thoughts and views will be beautifully supported by newer papers in future. So time above the range, glycemic variability, ambulatory glucose profile, nocturnal hypoglycemia, and postprandial excursions are better seen by CGM. So two patients with identical HbA1c values may have very different glucose profiles. This is true. Modern insulin titration should be guided by glucose patterns, not HbA1c alone. So people are stressing a lot. So in the days to come, majority of your patients will have a CDM implanted on the arm and they will show you the values. So the personalized insulin dosing over fixed regimes. ADA discourages rigid insulin schedules. Instead, insulin management should be personalized. Meal timing, portion size, physical activity, stress, illness, and daily glucose variability. This patient-centered strategy improves adherence and long-term control. Technology-supported personalization, definitely connected insulin pens are going to come. Automated insulin delivery devices are always there or already there. Smart dose calculators, real-time CGM guided titration. So नए जनरेशन के डॉक्टर्स को बहुत ज़्यादा टेक्नो फ्रेंडली होना पड़ेगा. बिकॉज आप नहीं होगे तो आपका पेशेंट तो रहेगा ही. दे आर ऑल AI trained now. They know about things. So इसीलिए बहुत सा डायबिटीज़ का एक प्लेटफॉर्म है विच ओनली टॉक्स अबाउट टेक्नोलॉजी, दैट इज़ ATTD। मोस्ट प्रॉब्ली एवरी ईयर दे टॉक अ लॉट अबाउट दिस। प्रीवियसली हमें लगता था यार क्या ज़रूरत है, अब समझ में आ रहा है it is something which is required. So insulin management in special conditions, we need to be well versed with hospitalized patients, pregnancy, older adults, CKD, and definitely with technology users. Technology users के साथ हमारी approach बदलनी चाहिए. So 2026 marks a shift from an insulin-centered approach to a patient-centered technology-enabled precision insulin strategy. The jumbling of words are also there. Sometimes ये word इधर shift हो जाते हैं, कभी उधर shift हो जाते हैं. But the emphasis is always patient. And dear friends, it is something we are ushering into an era where the things are going to be difficult for us if we are not techno-savvy. That is true. ये नहीं कह सकते कि CGM is not good, because people have accepted it and the science is running after such kind of technologies. So comparison of modern basal insulins, again, I will not take much of your time. Little bit with icodec once weekly, which is going to be launched. The duration of action is 196 hours, 7 days. Half-life is 196 hours, to be given once weekly. So we are excited about a new entry because it has been delayed. I don't know why it was delayed for the last 2 years. But somehow it is going to be launched now, very soon. Modern mealtime insulin comparison, again, Aspart, Lispro, Glulysin, faster Aspart, that is Fias and Lumj. These are the insulins. Rapid insulin, the Glulysin and all, because basically we have been using Aspart and Lispro. And now we use this faster Aspart also. It is all depends on the first phase of insulin secretion. There is rapid onset with respect to the ultra short acting insulin. They are trying to mimic the physiology. The moment you eat something, there is a sudden upsurge of insulin, the first phase of insulin secretion. That is very important. And these newer molecules, they act like the faster acting insulins. The first phase of insulin secretion is fast within few minutes. And it lasts for 1 hour. Previously, the regular insulin, the effect used to last for 4 to 6 hours. तो खाना खाने के बाद भी हो सकता था कि 4 से 6 घंटे में हाइपो हो सकते थे. The hypoglycemia chances are being lessened by these kind of insulin. And the sudden upsurge in the insulin levels, it mimics like what nature has given you, the kind of insulin pump जो आपको ईश्वर से मिला हुआ है. It mimics like that. And we are trying to mimic, we are trying to copy nature when it comes to insulins. So if GLP-1 receptor agonists are so effective, has the role of insulin diminished? ये question तो आएगा. Every now and then, every pharma company is coming to you with semaglutide. Can incretin-based therapies replace insulin? इसका कहीं ना कहीं मन में ये प्रश्न तो आएगा ही. Incretin-based therapies can delay insulin initiation, improve HbA1c and promote weight loss, reduce insulin dose requirements, lower hypoglycemia risks when combined with basal insulin, provide cardiovascular and renal benefits, and reduce progression to basal bolus therapy in selected patients. Insulin still remains essential for type 1 diabetes, ketoacidosis, hyperosmolar hyperglycemic state, severe symptomatic hyperglycemia, advanced beta cell failure, and pregnancy requiring insulin in many hospitalized patients. The future is not insulin versus incretins. It is insulin plus incretins. Sometimes in type 2 diabetes, I will not say type 1. Yesterday I prescribed it to a type 1 also, but I mentioned it was prescribed for obesity. So, but somehow it has got its effect. The alpha effect helps in type 1 also, but right now not approved, so should not be taught. So artificial intelligence in insulin therapy, the next frontier is AI dose calculators, predictive hypoglycemia alerts. Newer, that 780G Medtronic pump has got incorporated device like that. कि बच्चे को hypoglycemia होगा तो मम्मी के मोबाइल पे बीप आने लगता है. You जागो, बच्चा आपका hypo में जा रहा है. Such kind of things are going to come in big numbers in years to come. Automated insulin titration, machine learning, digital coaching, chatbot-assisted diabetes education. They are going to make your things simpler also if you are techno-savvy. They are going to make it very difficult for you. It can be a nightmarish kind of thing when you are not techno-savvy. What's coming in 2030? Glucose-responsive insulin. हम चाहते हैं ना ऐसा इंसुलिन हो कि साहब ने खाना नहीं खाया तो अभी असर नहीं दिखाऊंगा. We are talking about smart drugs. So in the years to come, the nanotechnology may bring something like that. Oral insulin, we people are desperately waiting for it. पेशेंट नहीं मानता तो मैं कहता हूँ यार 2-3 साल तो ले लो, हो सकता है 4 साल के बाद ओरल इंसुलिन आ जाए. तो समटाइम्स ये भी हथियार अपनाने पड़ते हैं. कभी कोई रेटिनोपैथी ले डराना पड़ता है तो कभी कुछ और करता है. बहुत सारे तरीके. आजकल मैं सबसे पहले यही बोलता हूँ यार, 3 साल पहले मैंने बोला था, अभी उस सर आए गायब हो गए थे. तो जस्ट काइंड ऑफ एग्जाम्पल समटाइम्स वर्क. मैंने कहा वो आँख में इंजेक्शन लगा रहे हैं. मैंने कहा आँख में तो छोटी सी चीटी भी जाने नहीं देते, वो भी करेला, वो भी नीम चढ़ा. एक एक इंजेक्शन 35-35 हज़ार रुपये का. तो मैंने कहा ये जो पेट में इंजेक्शन लगाना तो बहुत अच्छा छोटा सा है, इधर से जाएगा. तो सच काइंड ऑफ थिंग्स आप कैसे पुटअप करते हो, और किस स्ट्रेटा का पेशेंट है, और वो कैसे किस मेंटल मेकअप का है. इफ़ यू आर पुटिंग अप वर्ड्स, यू विल हैव टू प्ले वर्ड्स वेरी कॉशियसली. समटाइम्स ये बैकफायर भी कर सकता है, बट इट वर्क्स. दिस इज हाउ. कितना भी एआई आ जाए, ये तरीके तो यही रहेंगे आपको इंसुलिनाइजेशन के. So the diabetes like a team in India basically winning the match and better outcome with respect to metformin, strong start, improves insulin sensitivity, and it's a foundation therapy, GLP-1, SGLT2 inhibitors, DP4 inhibitors, lifestyle modification and insulin. So every successful team needs its match winner. Insulin steps in when the game gets tough and helps to us to win. So individualize, intensify, integrate, and empower. The right player at the right place and right time. That is something which is required in a clinical medicine. So insulin therapy has evolved from life-saving replacement to precision technology and applied care. Advances such as once weekly insulin, CGM connected devices, and AI are simplifying treatment while improving outcomes. The future lies not in replacing insulin, but in using it more intelligently through individualized patient-centered care. As diabetes management continues to evolve, the right insulin for the right patient at the right time will remain the cornerstone of optimal diabetes care. So insulin remains indispensable despite advances in incretin-based therapy. Early insulin initiation helps overcome therapeutic inertia and improves outcome. Second generation basal insulins provide longer, safer, and more flexible glycemic control. Once weekly insulin icodec is a major innovation. Ultra-rapid insulins for better postprandial glucose control, and CGM has shifted insulin management from HbA1c to time in range. So time in range is not a new thing, but in the years to come, there will be a stress on this. आप stress नहीं करोगे तो कोई patient बोलेगा. So this is how the scenario is. So precision insulin therapy should be individualized based on patient characteristics, comorbidities, and preferences. AI-connected insulin pens and automated insulin delivery are transforming diabetes care. ADA 2026 emphasizes simplified regimes, personalized care, and greater technology integration. This technology word can sound nightmarish, or it can be a boon to you, especially for the younger people. Get in more to all these AI kind of things because they are going to be integrated with our devices now. The future of insulin is smarter, simpler, and more personalized. Thank you. Thanks a lot. Yes, sir. Yes, sir. It's true, that can be stacking will be a problem, but what we have seen with Degludec, it was supposed to be given once in 3 days. Later on, they made it daily. There also the issue of stacking was raised. But these newer insulins, they doesn't lead to stacking. This is something what we have learned from Degludec. And let the once weekly insulin come. So the practical aspects of it will be learned the moment we'll start prescribing. I'm also raw. I've only learned, I've read. Dr. Goswami, do you would like to add on something for the icodec, once weekly insulin? Yeah. There's a relevant question he's asking in toto. Yes.
So if we look at it, then it acts uniformly over, say, 7 days. For example, when you are injecting 70 units, so it's 10 units every day. So you have to consider it the same as if someone was on 10 units of Glargine or 10 units of Degludec and then got admitted.
True.
So you have to keep that in mind, that this patient is on 10 units of a long-acting insulin every day and then add something. So that is how we have to think about it. So, not sure. We have to start using it and see how the dosing. But it is said that when you are initiating, in certain patients, you have to give 1.5 times the dose as the loading dose. So there is a loading dose protocol. For example, if the dose is 70 units a week or 10 units a day, then initially you can consider beginning with 100 units for the first week and then give 70 for the next weekly doses. There is a concept of 1.5 times loading dose with icodec. Huh? So I'll show some examples of how high insulin doses can be.
5,000. Sometimes in hospitalized patients it is possible.
So again, there could be what we call lipodystrophy syndromes.
Yes.
So you have to consider it like 10 units per day. That is what I
So
said.
what is your take, sir? Do you want to add on something, sir?
Yeah. In fact, the action is going to be like we use Degludec or Glargine. All the 70 units are not going to be available on one day. And as you can see, the action goes, little lower as the 7th day approaches, unless you are continuously, giving it and there is a level. So it's not going to be a problem. If patient has taken Glargine or Degludec और उसको accident हो जाता है, same way we'll take.
And regarding that very high dose of insulin, there are conditions called lipodystrophy syndromes, where there is very severe insulin resistance, where you might need very high doses, but adding pioglitazone often helps in those situations.
Sometimes the glucotoxicity is also there, lipotoxicity in sepsis.
This is once weekly insulin.
Yeah, icodec is once weekly insulin.
Prandial insulin then?
Definitely you'll be requiring it. आप खाना खाने के बाद जो शुगर बढ़ेगा सर. See, there will be lots of discussion when they will compare the use of icodec without a GLP analog and with a GLP analog. Let's wait for a few more months. You will hear those kind of discussions. So this is something which is new, and just because it has been launched in an era where semaglutide is widely and cheaply available. So बहुत सारे permutations and combinations आपको आगे सुनने मिलेंगे सर. सारे इंसुलिन ओरल थेरेपी के साथ चल सकते हैं सर, तो ये भी चलेगा सर. ये कोई बहुत अलग इंसुलिन नहीं होगा सर, बस आपको एक बार हफ्ते में लगाना पड़ेगा. पीपल आर फेंसिंग इट लाइक एनीथिंग कि यार वो हफ्ते वाला, पर वैसा नहीं होने वाला. प्रैंडियल डोजेस जब आप वो सुनेंगे तो उनको लगेगा यार ये तो क्या हो गया, क्या एक्स्ट्रा दिया आपने. Basal portion तो है तो, but type 1 में, even in type 2 also, who are not getting a very good control. Fasting के अलावा अगर control नहीं है तो फिर तो बहुत मुश्किल कर सकता है. हाँ, वो भी हो सकता है. बशर्ते वो इनहेल्ड इंसुलिन सस्ता कर दें सर. Yeah. Even cheaper, almost cheaper है, almost cheaper. तो उसको ना तो compatible prices पे launch किया.
Combine it prandial with the long acting once weekly.
हाँ चलेगा सर.
Is there any concept?
वो हो गई ना सर. प्रेंडियल की डोजेस को हम कभी भी डिनाई नहीं कर रहे हैं वंस वीकली में. वंस वीकली में ऐसा नहीं होगा कि भोजन के बाद अगर आपको इंसुलिन चाहिए पोस्ट प्रेंडियल कंट्रोल के लिए, तो दैट आइकोडेक इज नॉट गोइंग टू वर्क फॉर दैट. यूजुअली जो पुराना कंसेप्ट है बेसल इंसुलिन का, बेसल इंसुलिन दे अपार्ट फ्रॉम फास्टिंग 30% इम्पैक्ट वो स्पिल ओवर इफेक्ट होता है आपका एक पोस्ट प्रेंडियल मील पे, उससे ज़्यादा इफेक्ट नहीं होता सर उसका. तो वैसा आई डोंट नो, लेट्स सी व्हाट डॉक्टर गोस्वामी हैज़ टू से. सो आई इनवाइट हिम फॉर हिज लेक्चर. Dr. Goswami, the stage is yours.
So a very good morning to all of you, and I would first like to thank Dr. Sachin for inviting me to Bhopal. I've been to Bhopal several times before, but during monsoons it seems even more beautiful. So it is said that if you do the small things with great love or great sincerity, the big things, the great things will take care of themselves. And this is true not only in medical science, but also in life possibly as well. And when it comes to doing the small things with great love, insulin therapy is an area where it's very, very relevant. And I'll take you through 3 aspects of insulin therapy where we make certain common mistakes, where there are myths, misconceptions, and where we can do these small things with great love. One relates to storing insulin, one relates to how you administer insulin, and of course, how you choose the insulin that you are going to use. Now, I think Dr. Sachin has done an excellent job of taking us through how insulin therapy has evolved and where it's going to head. But often we are made to hear, particularly when we go to a lecture sponsored by an insulin company, there are slides which tell us that insulin is the most physiologic therapy for diabetes. So how many of you think that insulin is the most physiologic therapy of diabetes? Can I have a raise of hands? Okay, so theoretically, possibly to some extent, yes, but actually not, because there's a difference between endogenous insulin and exogenous insulin. So when your body has elevated glucose level, your beta cells release insulin, they enter the portal circulation, they act mainly on the liver, 50% is metabolized, they reduce hepatic glucose output, the rest goes to the periphery, acts at the muscle, the fat, and other organ systems of the body. And when the glucose starts coming down, insulin secretion from the beta cell is shut off. And this is a signal. If it goes down even lower, this shutting off of insulin is a signal for the glucagon to be released and avoid hypoglycemia. So endogenous insulin works like in a perfect fashion, almost like artificial intelligence. This is natural evolutionary intelligence at play when endogenous insulin is concerned. But when you're injecting insulin into the subcutaneous space, it doesn't go to the portal circulation. Most of it goes to the peripheral tissues, leading to peripheral hyperinsulinemia. Lower levels reach the liver, so it's an imperfect insulin. And it doesn't shut off its activity in itself, leading to hypoglycemia and weight gain. So yes, when you need insulin, you need insulin. There's no alternative. But the insulins that we are using, injecting into the subcutaneous space, is not physiological. It's the exogenous insulin that we are using. Now, first things first, we need to prescribe insulin, and often we come across prescriptions which are a bit difficult to interpret. So doctors have often been criticized for their handwriting, and these were prescriptions which we came across when we were students doing our postdoctoral degree in endocrinology. Now, if you look here, for example, if you look here, this place, so can you tell me the number of units which have been prescribed? Huh? 44, yes, and if you look there, it looks like 100 units of insulin. So a very common error which happens is using the symbol U, and not all of us can write U like it should be written. And if it's replaced, and if you think that that U stands for 0, there could be a catastrophic error for insulin. Similarly, using terms like BD before dinner, a nurse who might not have proper training might give it twice daily, the same dose twice daily. So when we are using insulin, prescription matters. Avoid using U, can write units, or avoid using anything related to U or units altogether. And avoid using terms like BD, because it's better to write before dinner or the full term. Now again, this was a patient who had come to us and who was storing insulin vials in the door of the refrigerator. Now we often have learned that you can store insulin vials in the door of the refrigerator, but for some reason, it was not working well. Now what had gone wrong? So as you can see, the freezer door is broken. So it happens in our homes. We have an old refrigerator, the freezer door is broken, and the entire cold blast was hitting the insulin. It was undergoing freeze and thaw cycles, and naturally the protein got degraded. Now, there is a lot of controversy as to where you should need to store insulin. Do you store it in the door, or do you store it somewhere else? Now, there's no one good answer, but I've gone through the literature extensively, And I feel that the best place to store insulin is the middle shelf of the refrigerator. The reason being that the door of the refrigerator is the one which is most susceptible to temperature variations. So you'll be opening and closing the door. In a busy household, you do it several times a day, leading to greater temperature fluctuations. If you have an older refrigerator, both the top shelf, which is close to the freezer, and the bottom shelf, because we learned in physics that cold air descends down, might be at lower temperatures than what is necessary. So the middle shelf of the refrigerator is possibly the safest place to store insulin. Now, how long can you use insulin after it has been opened, and how long can you store insulin in the refrigerator if you have not opened it? So if you store in the middle shelf of the refrigerator, you can store it for till the date of expiry. For example, the date of expiry is 8 months later. You have a cartridge or you have a vial, and you can keep it in the middle shelf of the refrigerator till the date of expiry. However, if you open a vial or if you open a cartridge, you have to use it preferably within a month, and the vial should be stored at less than 25 degrees centigrade, and the pen should be stored at less than 30 degrees centigrade. The vial and the pen need not necessarily be kept in the refrigerator. If you are confident that in the shade in your room, the daytime temperature, the maximum temperature does not exceed 25 degrees with a vial and does not exceed 30 degrees with a pen. However, in certain parts of India where the heat is more, the indoor temperatures might be more, and if your patient doesn't have access to a refrigerator, particularly patients who are using vials for economic reasons, then the so-called Zeer pot, where you have two clay pots, unglazed clay pots, one inside the other, can be used. You fill the space between the pots with wet sand, and due to evaporation in the hot and dry climate, the temperature in the inner pot is about 10 to 18 degrees lower than the outside temperature. And this works in areas which are hot and relatively dry. Patients who cannot afford a refrigerator, they can keep the vial in the inner part of the pot. Now, can anyone tell me, this is a quiz question, who first gave us the concept of this Zeer pot? Where did it arise first? So this is a 4,500 year concept. The Egyptians were the first to use this, and a Nigerian teacher in 1995 rediscovered or revitalized this concept, and it does work particularly in rural areas where patients don't have a refrigerator. Now, we were talking about high doses of insulin, not that high, but still high, as we see here, a problem of plenty. So this is a middle-aged gentleman weighing 56 kgs who was on 60 units of insulatard or NPH insulin and 90 units of regular insulin per day. So 65 kg body weight requiring 150 units of insulin a day. And he was also on metformin, he was also on pioglitazone, he was also on SGLT2 inhibitor, he was also on DPP4 inhibitor. And his HbA1c was reasonably controlled, not very well controlled. So what was going wrong? So any possibilities, what could have gone wrong? Not working, yes. That could be a possibility. Lipohypertrophy, yes. Technique, yes. These are possibilities, but what often happens is this. Now, can you tell me what's happening here? What's the problem here? So Sachin, being the trained endocrinologist, had spotted it correctly. So the problem in our country is that we have two different insulin concentrations available, and you need different syringes for those concentrations. So you have 40 IU insulin available in our country, which means that 1 ml of that insulin has 40 units of insulin. And you have 100 IU insulin available in our country, which means that 1 ml of that insulin has 100 units of insulin. So for example, if you use a 40 IU syringe, and from that 100 IU insulin, you draw 40. So you will be actually drawing 100 IU, 100 units, because 1 ml is 100 units, and vice versa. So in vice versa, the person who thought that he's taking 150 units is actually taking 60 units. So if there is a mismatch, it could result in a 2.5 times higher dose or 2.5 times lower dose. So you have to match the vial, the concentration of insulin and the syringe. The syringe, the red capped syringe is 40 IU syringe. The orange capped syringe is 100 IU syringe. And in what often happens is that for some unknown reason, people buy cartridges which are 100 IU, always 100 IU, which have to be put in the pen. They start using a pen, they do not like the pen, then they buy a syringe which is 40 IU and start taking that 100 IU cartridge with the 40 IU syringe, and then dosing difference problems occur. So this is something which need to be careful. Whenever you see that there is a dose response mismatch, other than lipohypertrophy, which has been shown here, where because of repeated injection at the same site, improper rotation, you have deposition of fat in the subcutaneous space and erratic absorption leading to higher doses, you have to keep in mind the syringe vial mismatch or the syringe cartridge mismatch in our country, because both these concentrations are available. If you look to your right, that is another reason for dose response mismatch. It's not very clearly visible from the distance, but what it shows is that in an insulin pen with a cartridge, there is air. There is a lot of air above the insulin, and if you say inject 10 units, you are injecting 4 units of air and only 6 units of insulin. So why does air enter the insulin cartridge in a pen? The commonest reason. Can anyone tell me? Okay. So a very common mistake that people using a pen do is that when using the pen, they store it in the refrigerator with the needle intact. This acts as an open straw. Again, physics. So we have learned in physics that when exposed to cold, things contract. So when you're exposing the cartridge to cold, both the insulin and the small amount of air in it contracts, and it pulls in air through the intact syringe, which acts as an open straw, leading to air entering the cartridge. So a pen in use usually does not need to be stored in the refrigerator if the indoor temperature is less than 30 degrees, and if you need to store it, you should store it with the needle removed. The needle should not be there while storing the pen in the refrigerator. We have published certain cases where we found that there were a lot of common dosing mistakes happening. For example, if you look at this gentleman, he developed an abscess. What he was doing was that he was washing the needle with tap water before taking it every time, and tap water might not be sterile. These things happen in our country. A lot of our patients, because of the concept while using older, longer needles, was that you have to inject at 45 degree, 30 degree. With the modern needles, you almost always have to inject at 90 degrees. So while trying to inject at 45 degrees or so, people often inject intradermally. And if you inject intradermally, you develop pigmentation, you might even develop an abscess at the site, as was seen. And of course, injecting in the forearms is a wrong site of insulin administration. So the next question is the injection painful? We have learned that the insulin injection is virtually painless, and it's actually painless. But if a patient comes to us and tells me, the doctor, I'm feeling pain while injecting insulin, what could be the problem? So what could be the problem? Too cold, yes, very good. Injecting cold insulin, taking it directly from the refrigerator. Not changing the needles as frequently as they should. Ideally, if you look at the needles, they are single-use needles. But for economic reasons, we say that you can use it for 4 to 6 times, not more than 4 to 6 times. Now, there are certain patients who are finicky about hygiene. They feel that they have to use an alcohol swab to clean the injection site. And if you use alcohol, and before the alcohol dries, if you inject through it, there is a silica coating of the needle which is damaged and which might lead to painful injections. If a patient on injection glargine comes to you and tells that I feel a burning sensation, just a cheeti kaat raha hai, like a slight burning tingling there, it's common because glargine exists in an acidic pH in solution, and when you inject it at neutral pH, it forms precipitates. So because of the acidic pH, if a glargine injection is like a cheeti kaat rahi hai, it's normal. It's not that there's something wrong with it. You have to tell the patient that it is because of the nature of the insulin that it's happening. And of course, an intradermal or intramuscular injection could be painful because these areas are rich in nerves. The subcutaneous region does not have significant nerves. Now the question is it better to use a pen or is it better to use a syringe? You're using the same insulin in both the pen as well as the syringe. So logically it would seem that they would act similarly, but again, possibly because of more convenience. In general, people are more adherent when it comes to a pen. Because of this adherence, possibly they attain better glucose levels. They have lesser physician visits. They have lesser visits to the hospital because of hypoglycemia resulting from dosing errors. And interestingly, they need lesser amount of insulin at the end of a year of follow-up to control their blood glucose. So overall, if your patient can afford a pen instead of a syringe, it leads to better outcomes over a longer period of time. But the other issue where cost is involved is to choose between an analog insulin and a human insulin. So are they different? So we know that we have the long-acting analogs like Glargine, like Degludec, and the intermediate-acting analogs like NPH insulin, Insulatard, which when used twice daily is almost like a long-acting analog. And amongst the mealtime insulins, we have the good old regular insulin, and amongst analogs, we have Aspart, fast-acting Aspart, we have Lispro, we have Glulysin. So if you compare the short-acting and long-acting analogs with human insulin, either intermediate-acting or short-acting, in terms of efficacy, there is nothing to separate them. They are similar, absolutely similar. However, there is lesser hypoglycemia with long-acting analogs compared to NPH insulin. Like with Glargine or Degludec, you have much lesser hypoglycemia, particularly severe or nocturnal hypoglycemia compared to Insulatard. But in type 2 diabetes, the same difference does not apply when we are comparing regular insulin to Aspart, Lispro, or fast-acting Aspart. Hypoglycemia in general in type 2 diabetes is similar with regular insulin versus Aspart, Lispro, or fast-acting Aspart, except in a few situations. However, the rapid-acting analogs are more convenient because you can inject them immediately before a meal or even 15 to 20 minutes after the start of a meal. So in terms of hypoglycemia, the long-acting analogs are beneficial, the short-acting ones are not. In terms of flexibility, the short-acting ones do give you some convenience. Now we'll quickly take you through a couple of cases before we sum up. So this is a case of a lady, a 58-year-old individual who has some microvascular complications, was on oral drugs till 6 months back. She had developed diabetes 11 years ago. She is on 4 oral anti-diabetic agents, sulfonylurea, metformin, SGLT2 inhibitor, DPP4 inhibitor, full doses. But as you can see, fasting postprandial HbA1c, she is not well controlled. To control blood glucose, because of cost reasons, instead of giving Glargine, NPH was given, Insulatard was given, it was up-titrated. The HbA1c did come down, but she's now complaining that I'm having frequent nightmares, early morning headaches. But when you did the fasting in the morning, you find that it's 192, it's very high. So what is happening here? So what's happening here, anyone? Yes, so this is what we call the Somoki phenomena. You develop early morning, 2 a.m. or 3 a.m. hypoglycemia. It stimulates the counter-regulatory response, and in the morning you develop hyperglycemia. So this is a classic situation where from shifting to NPH to Glargine, you avoid hypoglycemia, take the fasting into control as well, and improve blood glucose levels. So the lesson here is that in terms of nocturnal hypoglycemia, Glargine or Degludec is far better compared to NPH insulin, but the same might not apply to the analogs. As we said, we can use the analogs immediately before a meal or even 15 to 20 minutes after the start of a meal. But what if we inject a regular insulin or the premixed human insulin, hum insulin, human mixed, whatever, 5 minutes before the start of a meal? How is it going to happen? So there was a study in a small number of individuals, 15 individuals, however, which tried to look at this question, and they injected human insulin at different time points, 30 minutes, 15 minutes, 55 minutes before a meal, did the CBG at different time points, and did a 24-hour CGM. And what they actually found that even if you inject it 5 minutes before a meal, the glucose control is similar without an increase in hypoglycemia. So again, this doesn't mean that we can inject it 5 minutes before a meal in every patient, but in certain patients, well-controlled patients who are well aware, and if they do not want to inject 20 or 30 minutes before a meal, you can try injecting 5 minutes before a meal without loss of glucose control. So what about intensification? We have a patient, a 62-year-old lady, who is on full doses of 4 oral anti-diabetic agents, not well controlled. She was put on injection glargine. The dose was gradually increased. Her body weight is 57, and 3 years later, as you can see, she is on 30 units of insulin glargine, but her glucose level is still not well controlled. And Dr. Sachin was talking of over-basalization. So if your basal insulin requirement is more than half of your body weight, so 57 kgs, she is on 30 units of insulin, we call it over-basalization. So you need to add another insulin. Now the question is, in a person not controlled on basal insulin, what do you do? Do you shift her to premixed insulin twice daily? Or do you add a short-acting insulin, the so-called basal plus therapy? Again, you can do either, because studies show that in those not controlled on basal insulin, if you add a short-acting insulin versus if you shift her to premixed insulin twice daily, the number of people who attain glucose control without hypoglycemia is similar, but there are subtle differences. If you compare only shifting to premixed insulin, you attain somewhat better glucose control, but at the cost of hypoglycemia. If you add a short-acting insulin, you attain somewhat lower glucose control, but at a lower risk of hypoglycemia. So you can choose either depending on the patient that is in front of you. In someone who is relatively young, where you need stricter control, you can shift to premix twice daily. In someone who is elderly or with comorbidities, it's possibly better to add a basal plus, a short-acting insulin to avoid hypoglycemia and achieve somewhat less strict glycemic control. So you have to choose your horses according to your courses. The last case for the day. Here we'll be talking about further intensification. So a 64-year-old male, diabetes for 17 years, on 4 oral anti-diabetic agents. He was doing well till 7 years ago when he underwent CABG, and at the time of discharge, he was put on a premixed human insulin twice daily with metformin, DPP-4 inhibitor, sulfonylurea. Initially, it worked well, premixed insulin twice daily with other oral agents, but he started developing hypoglycemia, after which he sort of started reducing the dose of insulin. And because of reducing the dose of insulin, the blood glucose shot up. So in this patient, how can we improve his condition? Do we shift him to a biphasic analog, like say Humalog mix or Novomix twice daily? Or do we put him on a basal bolus insulin, like Glargine with 3 shots of regular, or say Degludec with 3 shots of regular, or an analog, whatever? So again, in someone who has experienced insulin therapy for some time, like in this patient, shifting from a premixed human insulin to a premixed analog insulin might not work wonders in terms of glucose control. And neither might it work wonders in terms of hypoglycemia, because as we discussed earlier, if you look at the short-acting component, difference in hypoglycemia in type 2 are not very similar, or not very different rather. On the other hand, in someone who has already experienced insulin therapy for some time, shifting to a basal bolus insulin is possibly the answer in terms of better glucose control, the most intensive form of insulin therapy in those with long-standing diabetes and who have already received insulin for some time. So to sum up, while prescribing insulin, we have to be very careful, either have an excellent handwriting or avoid using terms, short abbreviations. Best place to store insulin is possibly the middle shelf of the refrigerator, and you can use that clay pot concept in patients who cannot afford or who do not have a refrigerator at home. Proper administration, site rotation, avoiding storing the pen with the needle attached in the refrigerator, avoiding syringe vial mismatch are important in day-to-day practice. If your patient can afford, the pen is better than the syringe, but in terms of hypoglycemia in type 2 diabetes, the analogs are not different from regular insulin. However, the long-acting analogs are better in terms of hypoglycemia compared to NPH insulin. In certain patients, if required, you can try injecting a human insulin 5 minutes before a meal instead of 15 or 30 minutes, as has been seen from that study. The sort of insulin therapy which closely mimics physiology, again it cannot mimic our endogenous insulin, is basal bolus insulin. So in those on very long standing diabetes, already on insulin therapy for a pretty long time, you should intensify using basal bolus, but in those only on basal insulin, when you need to intensify using a next insulin, you can use either premix twice daily or basal with a short-acting insulin, the so-called basal plus therapy, which is more or less going to give you a similar result. So before ending, I have a small quiz question before you. So how many of you can identify this tennis player? He's going to play the Wimbledon finals tonight against Jannik Sinner. He is Zverev. So during the French Open finals, you can see Zverev, he was injecting insulin. He has type 1 diabetes from 10 or 11 years of age. And he needs to inject insulin if the matches are very long. So can anyone tell me, if you were his physician, what would you tell him regarding his insulin administration? Would you be happy how he's doing things, or would you tell him to do something else? Okay, that could be a point. Why? Not. Yes, exactly. So in people who are physically active and who are exercising or running immediately after administration, there could be increased, more rapid absorption if you inject it into the thighs. So after injecting in the thighs, if he starts running suddenly, as he would do, there would be more rapid absorption than what is expected, and it could lead to hypoglycemia as well. So if you were his physician, you would tell that it's better. Don't be shy. It's better to inject in your abdomen rather than your thighs, since you are a tennis player. And these small differences are what matters and what helps us bridge the gap between ourselves and the patients to improve their outcomes. Thank you.
Sir, if the patient is on optimal doses of oral hypoglycemic agent, and at which HbA1c level we must start insulin therapy, what is the guidelines?
So again, there's no hard and fast rule. You call it optimal insulin therapy. It depends on the background of the patient. For example, if the patient is young, has a long lifespan, then you would love to avoid complications. So instead of experimenting with a 5th oral antidiabetic, you would first push for insulin. Again, in a patient who has developed early complications, retinopathy, early nephropathy, you would push the patient to take in insulin early. On the other hand, in someone who is at an advanced age, has already advanced kidney disease, advanced heart disease, limited life expectancy, you might not push that patient that much to take insulin. And your HbA1cs would also differ similarly. In that younger patient, even at 7.5 or 8, you would be sort of eager to start insulin early. In someone with limited life expectancy, even at 8, 8.5, as long as there are no osmotic symptoms, no underlying infections, you might wait for some time. So it depends on the patient who is in front of you. You have to choose your targets likewise.
I want to give some message. Nobody is examining the patient now.
Yes, sir.
Only seeing the patient.
Unfortunately true, sir. Unfortunately true.
Teacher says, please bow to a patient.
Yes, sir. Very true.
So many patients taking pioglitazone and insulin.
Pedal edema.
And getting weight and
Volume overload.
going towards the heart failure.
Particularly with
But
insulin.
nobody is
Yes,
seeing
sir.
the weight. How much weight we will wait for pioglitazone and insulin increase?
So usually the weight gain is 3 to 5 kgs, not more than that. If you see abnormal weight gain, that could point to volume overload and incipient heart failure. So a lot of 10 kgs, 15 kgs, that shouldn't happen. That much adiposity doesn't increase. So if it's more than expected weight gain, always look for incipient heart failure. And with injection insulin at every visit, make it a point to examine the abdomen, because a lot of our patients, a huge number of our patients have lipohypertrophy, and that leads to problems.
In my mind comes different patient having different degradation of insulin, enzymatic.
Yes, sir.
So if somebody
So that is why it's not a perfect therapy.
So how we can judge the enzyme status?
So it can only be possible by routine capillary blood glucose monitoring. So you have to, after initiating insulin, at least for the first few weeks, you have to do some hand holding. Do the CBG every 2 to 3 days, get back to me, and up titration, down titration. So the response is different in every individual. That fixed dose-based approach, body weight doesn't work. So some hand holding initially where you have to up titrate, down titrate is necessary in every
We
patient.
can change the enzyme degradation due to some in future.
Possibly, sir, we have to wait for that.
Some patients develop fluid retention on insulin therapy and some don't. Why is that?
So again, what happens is that it increases sodium absorption in the renal tubules, insulin. So even with pioglitazone, because of increased sensitivity, it occurs. With insulin therapy, it might occur. But that's a necessary evil. You have to do with that, because when you need insulin, you need insulin. Similarly, we know that pioglitazone worsens macular edema. Even insulin can worsen macular edema. But you don't have a way out. When you need insulin, you need insulin.
Can semaglutide be combined with insulin therapy?
So yes, I think that once weekly, they are working on that. Semaglutide with icodec, icosema. So we might have that in our country sometime at point of time. Thank you.
It was a masterly act. Thank you. Thanks a lot. So our master classes are very interactive, and please ask more questions, because Somik has come to our master class for the first time. He should have that kind of impression. And the way he must have got the grip also, the way that there are so many answers which are coming spontaneously here, and that is something great. And that injection portion, sir was rightly pointing out, कि भाई पैर में नहीं पेट में लगाना चाहिए. That was a good thing. So that is something which is very candid for masterclass. So I take the opportunity to invite Dr. D.C. Sharma, sir. So now the stage is yours, sir.
Good morning, dear friends. At the outset, my sincere thanks to Sachin for inviting me to this beautiful city of lakes. So I bring greetings from City of Lakes, Udaipur, to this City of Lakes. And I found so many similarities between Udaipur and Bhopal. I landed yesterday and was traveling to hotel, and I thought that I am in Udaipur. Lakes and small hills, and so beautiful city. Thank you. So friends, we had two wonderful and lectures of more practical utility. And again, this lecture is also going to be of practical utility, because diabetic patients are very often subjected to surgeries. They are hospitalized more frequently than non-diabetic patients. And it is very important that we control their blood glucose optimally so that we achieve the target, and our patients are not subjected to unnecessary hyperglycemia or hypoglycemias. And let me disclose that this is a sponsored lecture. I am speaking on behalf of CIPLA. So friends, diabetic patients are 3 to 4-fold higher, at risk for hospitalization as compared to those without diabetes. And there are several reasons for hospitalization: more frequent ulcers, infections, more frequent surgeries, more frequent CABGs, more frequent renal transplantation. So they are subjected to surgeries more frequently than non-diabetic patients. And more the HbA1c, that is, worse the blood glucose levels, higher are the chances of their hospitalization, because with the higher HbA1c levels or higher hyperglycemia, more infections, more limb ulcers and toe ulcers. So worse HbA1c, higher chances of hospitalization. Now, hyperglycemia impacts the surgery outcome as well as the overall results of surgery, because uh, with hyperglycemia there are higher chances of infection, the higher chances of delayed wound healing, prolonged hospital stay, higher morbidity and higher mortality. So what is required is, when your patient is planned for surgery or admitted for emergency surgery, at least optimum glycemic control or acceptable glycemic control should be achieved. And what is the target? Target for hospitalized patient is somewhere between 140 to 180 milligram per deciliter. There have been several landmark trials, and just I would name some of them: the GAMI trial for cardiac patients and NICE sugar trials. And let me explain here why we want blood glucose between 140 to 180. The trials have shown that if you keep your patient at a very stringent control, less than 140, there were higher mortality. There were higher chances of hypoglycemia leading to arrhythmias and cardiac mortality. So the acceptable target for a hospitalized patient is between 140 to 180 milligram per deciliter, whether patient is in ICU or in general ward. Now, if it is a elective surgery, then the outcome would be best or optimal if we prepare the patient for surgery before hospitalization. And if there is a need to change the oral drug, appropriate changes in the oral drugs, some of the drugs, oral tablet needs to be stopped, and you introduce insulin well in time, would give you better results. And while in the hospital, frequent blood glucose monitoring so as to bring blood glucose to the target, and shifting the patient, preparing the patient to discharge adequately would also add in the a better outcome. Say while the patient is in ICU and needs to be switched to shifted to general ward, switching from IV infusion to subcutaneous insulin again requires education and proper monitoring, and preparing the patient to for discharge so that at home after leaving hospital he is not having unnecessary hyperglycemia is also important. So taking care of pre-hospital, in the hospital, shifting from ICU to general ward, and preparing for discharge, at every step we need to be careful, and proper education and monitoring is required. Now, what is the indication for insulin in hospital settings? Insulin is required in almost all the patients when there is a moderate to severe hyperglycemia, whether it is critically ill or non-critically ill. If the blood glucose is persistently more than 180 milligram per deciliter in any hospitalized patient, insulin is required. Less than 180 milligram per deciliter, insulin may not be required. You just be careful with the monitoring and give appropriate IV fluids. So insulin therapy in the critical care setting, and I'll give you just outline of how do we initiate insulin in critically ill patient, in ICU patient, and in non-critical setting. So the indications for insulin therapy in critical care are any patient with uncontrolled hyperglycemia despite multiple subcutaneous insulin injection. If there are hypos and hyperglycemias with the SC subcutaneous injections, during childbirth, emergency surgery, critically ill patient admitted with diabetic foot, septicemia, during perioperative period, and for organ transplantations, when a patient is admitted with hyperglycemic comas, say hyperosmolar or diabetic ketoacidosis, obviously IV insulin infusion is required. When patient is receiving high dose glucocorticoids, we witnessed during COVID period that most of our patients were having blood glucose above 400 and 500 milligram per deciliter, requiring IV insulin infusion. So these are the situations when you require insulin infusion in the critical care unit. Now, the key features for insulin infusion protocols are that you have to first decide the insulin infusion, insulin dose, at what insulin dose or infusion rate you would be giving the insulin. Then rapidly achieving targeted blood glucose levels, that is between 140 to 180. Clear algorithms needs to be understood, and minimizing hypoglycemia and hyperglycemias. And then the staff needs to be trained. The doctor cannot be present all the time, and the ICU staff or the ward staff should be properly or adequately trained so that they implement your algorithms and monitor the patient properly so that unnecessary swings are avoided. This is just an example of insulin infusion protocol, just a guideline, because insulin dose depends on many factors. Number one, the physiological requirement, but on the top of that, stress. Stress can be different in different individuals. Stress can be because of associated infections, associated, drug use. Say, for example, patient on glucocorticoids, they require many times the normal physiological dose. Remaining, hungry, or stress because of hospitalization itself. So this is a general guideline that if blood glucose is less than 100, don't give insulin. Don't initiate insulin. Just observe and see that patient doesn't go in hypoglycemia. Blood glucose between 100 to 149, a dose of 1 to 1.5 unit per hour. And this is by continuous insulin infusion by the pump. If the blood glucose is between 150 to 199, 2 units per hour, and likewise you increase the dose of insulin infusion as the more hyperglycemia is there. This is just a protocol I am reading out for you. Step 1 is load insulin, a practical demonstration that how you start. Load insulin by adding 25 units of short-acting insulin to 250 milliliter of normal saline, so that you have a solution of 0.1 unit per ml solution. Flush 50 ml of insulin via insulin infusion tubings to saturate the binding sites in the tubings. The next step would be give bolus dose of insulin. To decide the bolus dose, divide the current blood glucose by 50. For example, current blood glucose is 250 milligram per deciliter. You give, say, 2.5 units of insulin as a bolus dose. Then set the hourly insulin infusion on the infusion pump. Infuse at a rate of 0.5 unit per hour in thin women and 1 unit per hour in other patients. So 0.5 to 1 unit per hour dose is to be infused. Then based on the blood glucose monitoring results, you increase the up titrate or down titrate the dose. Readjust the dose by checking blood glucose every hourly so as to achieve a blood glucose value of 140 to 180. Prevent hypoglycemia. The moment the blood glucose is less than 100, stop infusion. Observe. If blood glucose tends to go below 70 or 80, infuse with 25% dextrose. And one very important precaution is always overlap subcutaneous insulin with the IV infusion when you plan to stop infusion. So before stopping infusion, give subcutaneous insulin at least 30 minutes before stopping the infusion, so that adequate amount of insulin is already there in the circulation and there is no unnecessary hyperglycemia. This is a common mistake that when we receive patient from government hospital or discharge patient कि डॉक्टर साहब वहाँ 5-6 बार मुझे कीटोसिस में चला गया, ठीक करते वापस कीटोसिस में चला जाता. This was because you would stop infusion and delay subcutaneous insulin therapy, or the next SC insulin would be delayed by 3-4 hours, and by this time hyperglycemia supervenes, patient again goes into ketosis. So always overlap subcutaneous insulin therapy with IV infusion. Give it at least 30 minutes to 2 hours before stopping the infusion. If the blood glucose continues to rise, up titrate the dose. Say if the blood glucose doesn't fall below the expected level, increase it by 10%, or maybe more doses required. Then the next step would be transitioning from IV infusion to subcutaneous. Once the patient is stable, we are planning to shift him from ICU to general ward, then what is to be done? A structured transition from IV insulin to subcutaneous insulin reduces morbidity. Give SC basal insulin 30 minutes to 2 hours before stopping IV to prevent hyperglycemia. SC insulin, now how to decide the dose? SC insulin dose is based on the stable IV insulin rate over the last 6 hours. And calculate the total daily dose by multiplying 4 by the insulin infusion in last 6 hours. Let me give you an example. In the last 6 hours, if the patient was receiving 1 unit per hour, so how to decide? In last 6 hours, patient was receiving 1 unit per hour, means 6 units over 6 hours. Multiply it by 4, that is 24. So in next 24 hours, you are going to give 24 units in the next 24 hours, 60% of this as basal insulin, and 40% is basal insulin and 60% is boluses. That is, say almost 8 to 10 units as long-acting insulin, glargine or degludec, and divide boluses into equal part, say 8, 7, 7 or likewise. So 40% is basal insulin and 60% equally divided into 3, boluses. Then adjust the dose based on ongoing IV fluids. If the patient is receiving dextrose, for example, for nutrition, then you will have to give additional doses of short-acting insulin. If the patient is receiving steroids or inotropes, again the requirement of IV infusion may be higher. Then transitioning from critical to non-critical setting, it depends whether the blood glucose or the previous blood glucose status of the patient. If the patient was having mild hyperglycemia before hospitalization, the patient was receiving, say, only 1 gram of metformin, or he was managed with just 1 or 2 milligram of glimepiride, transitioning from ICU to the ward, he may not require any insulin. Or if the blood glucose, if the patient was on 2-3 tablets along with say 10 units of basal insulin, then you might start with just basal insulin and observe. Observe preprandially. If the blood glucose is still in the range of 180 milligram, patient may not require additional boluses of short-acting insulin. So in addition to the basal insulin, patient may require boluses if the blood glucose, postprandial blood glucose is more than 180 milligram. So this all depends on your monitoring results. Mostly you initiate with basal insulin, and if the food intake is predictable, that patient is started taking, accepting orally, no vomiting, no nausea, you can even introduce on 3rd, 4th, 5th day of surgery or getting better, a small dose of metformin if everything is fine. So let me discuss a case. Here is 52-year-old gentleman who is 84 kilograms, type 2 diabetes for 4 years, currently on metformin 1500 milligram and glimepiride 2 milligram. He has a history of fever and getting admitted for fever and abdominal bloating and discomfort. His random blood glucose is 200 milligram per deciliter, ketones negative, HbA1c 8.4, and blood glucose fasting 150 milligram, and postprandially around 220 milligram. Now he requires to be switched over to insulin. So patient was started on insulin, oral drugs were stopped. His total daily dose started at a rate of 0.2 unit per kg. Then he was switched over to basal bolus insulin therapy, 8 units as basal insulin, and rest of the 8 units were given in 3 divided doses, 3, 2, 2. 3 units before breakfast, 2 units before lunch, and 2 units before dinner. Then based on the blood glucose levels, the basal insulin or the prandial insulin dose can be increased or decreased. Now, second case would highlight how to achieve glycemic control in the hospital. Again, patient with metformin 1 gram BD, glimepiride 2 milligram, glargine insulin 20 units at bedtime, and Lispro 4 times, 4 units, 5 units, and same units before each meal. So when the patient is getting admitted to a hospital and we are expecting a major surgery means, in simple terms, I would call major surgery as one in which the next meal is not anticipated, cannot be given, or if a major cavity is opened, say thorax, peritoneum, or a major surgery, and when patient is undergoing surgery under general anesthesia, then obviously oral medications needs to be stopped. All longer acting sulfonylureas should be stopped at least 3-4 days before planned surgery. So glimepiride, glibenclamide, glipizide should be stopped at least 3-4 days before surgery. Again, SGLT2 inhibitors should be stopped preferably a week before or at least 3-4 days before planned surgery, because SGLT2 would lead to more chances of dehydration, more chances of UTIs. So SGLT2 inhibitors specifically should be stopped 3-4 days before planned surgery. Metformin should be stopped at least a day before planned surgery. If a patient is receiving once in a week semaglutide, fine, it's not going to interfere. there was a question of icodec. I think icodec, if patient has received icodec and he is subjected to surgery third, fourth day, it would not matter much. Only thing is we need to monitor properly so that patient, since patient has insulin in the circulation, it doesn't go in hypoglycemia. So proper monitoring would be required. So this patient, his glargine dose was increased and Lispro was given 8 units before. This is a theoretical example, and let me highlight that our patient require much more amount of insulin. Say patient admitted with the bad diabetic foot. His insulin requirement is 3-4 times what he was receiving earlier. Say earlier he was receiving 30 units, 36 units of insulin in a day. The requirement of insulin may go above 100 units per day because severe sepsis and insulin resistance. So it all depends on monitoring results and what underlying associated medical condition is. Now there are two types of short-acting insulin Lispro available, 100 units and 200 units. In which patients to use higher strength insulin? When the short-acting analog is used for boluses, this Lispro is used for pre-meal boluses. So when the pre-meal boluses dose is higher, say if the patient is receiving 10 units 3 times or 15 units 3 times, then to reduce the volume of the injection so that the discomfort of injection site is less, you can use 200 unit insulin. Otherwise, they are action-wise 100 IU or 200 IU is same. So to summarize insulin use in critical care patient, the target is to maintain blood glucose between 140 to 180. Preferred route is IV infusion. And in ICU, we have two separate lines. One line giving IV fluids, say normal saline or RL, ringalectide or isolate M or dextrose, but taking care that if the patient is receiving glucose containing fluid, say 5% dextrose or glucose normal saline or dextrose normal saline or isolate M, which has got 5% dextrose, you have to keep in mind that patient would require additional doses for taking care of the glucose containing fluids. And another IV line being infused with insulin. Frequent monitoring is required, preferably every hour or at least 1 to 2 hourly, and maintain blood glucose in the range. The moment blood glucose tends to go below 70 or 80, stop infusion. If required, IV glucose or IV dextrose to be given. Then proper transition from IV infusion to subcutaneous insulin therapy is required. In non-critical hospitalized patient, how to manage? Again, it should be a planned surgery if possible, then take out oral medications, stabilize the patient. The question is frequently asked that if the patient is receiving oral, small dose of oral tablets, say patient is maintained on metformin 500 milligram twice and he has to undergo surgery next day. Shall we continue? You can give nighttime metformin also. You can give nighttime basal insulin also and take care that fasting blood glucose is normal. The only thing is you monitor blood glucose. So schedule insulin regimen that includes basal, nutritional and correction doses. So you give in the hospital patient basal bolus therapy, and in addition to basal bolus therapy, correction doses. That is, if the postprandial blood glucose is still 250 milligram, you might give 1 unit or 2 units of additional dose to correct the blood glucose. That is called as correction dose. So basal dose, prandial dose and correction dose is required. Approach, I mean, there are two types of therapies. I am talking about basal bolus insulin therapy, and other therapy which is frequently used and which should not be used is sliding scale. Sliding scale is nursing staff is more familiar and they are more comfortable कि आपने चार्ट लगा दिया ICU में कि 200 मिलीग्राम है तो 2 यूनिट लगा देना, 300 मिलीग्राम है तो 3 यूनिट्स लगा देना, and this is sliding scale. But in sliding scale, we are chasing the hyperglycemia rather than being proactive.
Yes.
We are chasing hyperglycemia. 300 यूनिट है, हमने 3 यूनिट्स लगा दिया, then 100 मिलीग्राम है, हमने इंसुलिन नहीं दिया. We are allowing blood glucose again to go up. So this is a failure approach. We have to be proactive, and basal bolus insulin therapy is a proactive approach. In hospital, whenever insulin is required, in addition to basal insulins, it should be basal plus, as highlighted by Dr. Chaumik, that in addition to basal insulin, 1 or 2 boluses of prendial insulin, short-acting insulin, or finally basal bolus insulin therapy. More practical, more safe approach. Here, the glycemic control is stable rather than fluctuating blood glucose as we see in sliding scale. So there have been some trials of basal bolus insulin therapy in surgery patients, Rabbit-2 trial, and you can see the upper graph showing more blood glucose levels with the sliding scale, and the lower graph is showing more stable blood glucose, better blood glucose with the basal bolus insulin therapy. Similarly, in the medical patients also, the trial was Rabbit-2 surgery and Rabbit-2 medical trial. Again, better glucose results, more stable blood glucose results can be achieved with basal bolus insulin therapy in hospital patients. So we no more used sliding scale. So as highlighted early, the insulin is required in all patients with poor glucose control, stress hyperglycemia, newly diagnosed hyperglycemic patients, patient in ketosis, patient with major surgeries, patient in seriously admitted in ICUs. Now, how to titrate insulin doses in non-ICU patient? First, you adjust basal dose. How to adjust the basal dose? If the patient is receiving, say, degludec or glargine insulin, we always set the dose of basal insulin based on fasting plasma glucose. So, based on the fasting plasma glucose, you up-titrate the dose of glargine insulin or degludec insulin. The dose of glargine insulin or degludec is mostly 0.2 to 0.3 units per kg body weight. Say, for example, if the patient is weighing 60 kilograms, you initiate with 60 into 0.5, right? And then up-titrate the dose. So every second or third day, increase the dose by 10% or 2 to 3 units. And this is how you are going to prevent hypoglycemia and achieve the desired blood glucose levels. Once the fasting plasma glucose is achieved, and if additional doses are required of short acting based on the postprandial, आपका fasting तो ठीक आ गया, but post lunch is always high, then initiate small dose of basal insulin, bolus insulin, short acting insulin pre-lunch. And what should be the dose? 10% of the basal dose. If the basal dose is say 30 units, start with 3 to 4 units. So on safer side, 3 to 4 units of prandial insulin before meals, and then titrate the doses based on post-meal and next pre-meal. See, if I'm giving 3 units at lunch, and if post-prandial blood glucose, post-lunch blood glucose is still 220 or 230, and pre-dinner is still 200, then I'll increase the dose by 1 to 2 units next day and achieve 180 milligram post-lunch and around 140 to 160 milligram pre-dinner. So this is how you titrate and achieve the desired goal post-prandially and in the fasting state. Managing hypoglycemia is important. If hypoglycemia is mild, you can manage it by oral glucose. To define hypoglycemia, there are 3 levels of hypoglycemia: level 1, level 2, and level 3. Level 1 is when fasting plasma glucose is between less than 70. And level 3 is severe hypoglycemia, less than 54, and patient requiring assistance. Someone else is required, patient is unconscious or not in a state to comprehend. So this is severe hypoglycemia, level 3 hypoglycemia. We know the symptoms of hypoglycemia divided into neuroglycopenic symptoms and adrenergic symptoms. Adrenergic symptoms, anger, tachycardia, tremors, and likewise neuroglycopenic symptoms are various grades of altered sensorium and comprehension, and ultimately unconsciousness and coma. So the frequent causes in hospitalized patient which would predispose the patient to hypoglycemia are missed meal, inadequate meal, vomiting, nausea, diarrhea, then interrupted pattern of feeding, steroid use which would require higher doses predisposing to hyperglycemia and hypoglycemia, renal failure, impaired renal function, impaired kidney function, undiagnosed hypothyroidism. So all these conditions to be closely looked when patient has unexpected hypoglycemias. Identify and treat them. Managing hypoglycemia. To simplify this this diagram, if patient is in a state to accept orally, 20 grams of glucose or sugar should be given. Recheck blood glucose 15 to 20 minutes later and ensure that your blood glucose is above 100. And if next meal is anticipated, patient can take orally, ask him to take his routine meal. If patient is not in a state to take orally, then give IV dextrose 25%, 100 ml dextrose, 50 or 100 ml dextrose, and recheck blood glucose 15 to 20 minutes later. If required, repeat, or a patient can have his next meal. Insulin perioperative care, this again is an important topic, but mostly the same principle applies for perioperative period also, that most of the patients are required to be on infusion or at the most basal bolus insulin therapy. And the result, the outcome depends on proper monitoring and avoiding hypoglycemia. Discharge planning is important. If the patient is now stable, hospitalized patient is stable, accepting orally, but still we know that most of the patient the food intake would be less than their routine food intake. They go home and their food intake improves, or their physical activity improves. So there are chances of hyperglycemia and hypoglycemia. So proper discharge education is important. Now this depends on who is taking care of the patient. If the patient is taking care of himself nicely, then the education should be given to the patient. If family or relatives are taking care of him, then all the family members or one who is going to take care of him at home should be educated. Or if some nurse attendant is going to take care of the patient at home, the nurse or the nursing staff should be properly educated for monitoring and dose adjustment. And this is the time we should spend most of the focus should be on the discharge planning. Your educator, your dietitian should spend at least 30 to 40 minutes to explain the monitoring, the dose adjustment, and anticipated swings in the blood glucose and how to correct them when patient goes home. So friends, to summarize, I would say that insulin is the preferred therapy in any hospitalized patient, whether admitted to ICU or non-ICU, and especially if meal intake is unpredictable. When insulin is to be used, mostly it is insulin infusion in critically ill patient or severely ill patients. While if the patient is not very seriously ill, basal bolus insulin therapy is preferred. The glycemic targets are 140 to 180 milligram per deciliter. Avoid hypoglycemias, recognize hypoglycemia, treat hypoglycemias immediately, and proper monitoring, transitioning, and discharge planning is important to prevent swings and for better outcome in terms of surgery and overall health. Thank you very much.
Thank you, sir. Thanks a lot. Now the house is open for questions.
One thing from you.
Sir.
You have not discussed labile diabetes. Patient, the same dose, hyperglycemia. So many patients come.
Yeah.
Second, nowadays, because the medical cost is so much, so we have surgeon saying, come tomorrow, I will operate in the evening. How many days before the patient should be in major surgery, admitted and regularly seen by the surgeon?
The first question first, labile hyperglycemia, we frequently come across patients going to hypoglycemia and hyperglycemia. This is because of maybe unpredictable meal intake. When anticipated meal is not there, patient is vomiting. You have given, patient has received degludec or icodec or whatever, and now not able to eat. You have given short-acting insulin and patient is vomited out. So the answer is proper monitoring. If you are properly monitoring the patient and patient is going into hypoglycemia, can be avoided by giving IV dextrose or oral glucose. So monitoring is important, and you have to see, I've mentioned all the predisposing factors for hypoglycemia. So if patient has a renal impairment, he is more likely to go into hypoglycemia. On steroids, hyperglycemias. So all these factors are to be carefully looked at.
Second, how many days before should patient?
Right. If it is a planned surgery, proper pre-operative planning should be done. As I mentioned, the longer-acting sulfonylureas, glitazone, the SGLT2 inhibitor should be stopped, and preferably, if it is going to be major surgery, admit the patient 2-3 days before and put him on basal bolus insulin therapy. If it is an emergency surgery, then just monitor the blood glucose levels and give short-acting and long-acting insulin accordingly, or IV insulin infusion.
I have seen one patient yesterday,
It's a frequent problem, sir. Yeah.
type 1.
और आपने जो बताया कि surgeons are in a hurry, that patient might run away. So I have to operate him today itself, today evening itself. And there are some genuine emergencies also. Say diabetic foot or gangrene comes. Yeah. So in that case, properly monitoring and achieve an acceptable metabolic control. Acceptable metabolic control is, say patient is in ketosis, severe ketosis. We can't wait. So wait for at least 2-3 hours, stabilize his electrolytes, stabilize his blood glucose levels, and let the patient have acceptable metabolic control. Uska pH better ho jaye, then you
During
operate.
ketosis, we can operate.
No, sir. Preferably not. No, not. But if say for example कोई dire emergency आ रही है, 4-6-8 घंटे में patient को हम better condition में ले आएंगे.
Yesterday, I have seen one patient, type 1 diabetes and Addison disease, taking 4 tablets of corticosteroid and no space for insulin injection.
Oh.
And he's taking corticosteroid, insulin 3 doses. So what we will do, where we will inject the insulin?
So no space for
Chicken pox. Yes.
chicken pox. So you have to see the the
Go
skin,
for the IV
intact
therapy.
skin between the
Yes, on the excess.
Oh.
yeah.
Yes.
So you have to find some skin where you can inject, not necessarily thigh or abdomen. You can inject anywhere.
Because
In emergency, you can
Rash is
inject
so
even on the
severe.
back. Only thing will be the insulin absorption will be little slower on the back. You can inject anywhere,
we have to,
wherever there is subcutaneous insulin.
because he's on corticosteroid for we will increase the corticosteroid antiviral. So we will increase the dose of insulin. with the-
Obviously, if the patient on a steroid, many times higher insulin doses would be required.
Thank you.
Sir, what should be the rate of the fall of the blood glucose in critically ill patients by the insulin infusion?
Okay.
And second is whether you should give the potassium or not in such patients.
Right. So the rate of fall in a very mild hyperglycemia should be around 50 milligram per hour. If it is not falling below 50 milligram 1 hour, then you increase the dose by 1.5 to 2 times. So 50 milligram per hour if blood glucose is very high, say 350, 400, 450 or 500. Up titrate the dose, make it 1.5 times or twice. Regarding potassium, if you are giving insulin and glucose infusion for a prolonged period, obviously this might predispose you to hypoglycemia. So there is a recommendation for GIK, glucose, insulin and potassium. So each 500 ml of dextrose can be combined with 10 to 20 milliequivalents of potassium. So in prolonged surgery, say patient undergoing CABG or some other complicated surgery where insulin infusion is to be given for 6 to 8 hours, combined with GIK, potassium,
So whether it should
and
be
monitor potassium.
so whether it should be increased to 100 milligram per hour or not. It is the 50 or less or more than 50 milligram per hour.
So 50
Fall.
milligram, 50 milligram lowering blood glucose by 50 milligram per hour
Per hour.
is to
If it is falling more than 50 or it is
reduce the
falling-
insulin dose, reduce the insulin infusion rate.
Usually around 50 to 75 is permitted.
Because with such a drastic lowering of blood glucose, there are higher chances of hypoglycemia.
No, but it's a-
If some patient has wrongly taken bolus insulin instead of lethal insulin, so how much glucose should be given for like 10 units of lethal insulin and he has taken 10 units?
So there is no fixed formula. You just
You'll have
need
to
to
observe
monitor. And in anticipation, you can give small amount of glucose orally. Patient is conscious. So अगर blood sugar आपका 70-80 से
Sometimes,
नीचे जाने लगे, ask him to take extra glucose and extra chapati and watch. And the effect is going to go away within 3-4 hours, because the peak action of the regular insulin is going to be around 3-4 hours after injection.
So thank you, sir. Thanks a lot for the erudite
Thank you.
lecture. I take the opportunity to invite our dignitaries, Dr. Kailash Singhal, Dr. Vijay Pagare, sir, Dr. Moiz Hussain, and Dr. B.M. Loya, sir, for lighting of the lamp. Please, sir. आइए। Sir, आप भी आइए, sir. आइए for the lighting of the lamp. So I take another opportunity to invite Soumik. Dr. Soumik, the stage is yours.
So very good afternoon again. Life can be boring if we are constantly walking on the footpath. So to make life exciting, once in a while we might need to walk on a tightrope. So if you look at your practice, then managing type 1 diabetes is like walking on a tightrope. It's very difficult. It's very exciting as well. And similarly, using insulin in patients with kidney disease is always like walking on a tightrope, and accidents can happen at any point of time. So I cannot promise that I'll help you master insulin use in diabetes, because I am still learning, particularly in regard to kidney disease. But let us see at the pros and cons at the literature that we have with regard to use of insulin in patients with kidney disease. Now, when we think of the kidneys, we think of the kidneys as the main organ involved in excretion. And we often forget that the kidneys are actually metabolically very, very active. If you look at glucose homeostasis, the kidneys eat up about 10% of your blood glucose, and when you are fasting, they generate about 25% of the glucose that comes from gluconeogenesis. A lot of glucose, about 180 grams, is filtered every day, and more than 90% of it is absorbed by the sodium glucose transporters, which we are inhibiting when you are using the SGLT2 inhibitors. And in diabetes, this process of taking up glucose, giving out glucose, reabsorbing glucose is increased several folds. The net result of which is that, just like the liver contributes to hyperglycemia in diabetes, the kidney contributes to hyperglycemia in diabetes as well. This is the glucose part of the story. What about the insulin part? So we have learned in our physiology classes that the endogenous insulin, which is produced by the beta cells, is mostly metabolized by the liver. 50 to 70% of the endogenous insulin is metabolized by the liver. A small amount, about 1/4 of the beta cell secreted insulin, is metabolized by the kidneys. But in a patient who is given insulin from outside, the exogenous insulin, not so perfect insulin as we discussed earlier, but necessary for improving outcomes, the exogenous insulin is mostly, almost 80%, up to 80% of the exogenous insulin is metabolized by the kidneys. So naturally, when your kidneys are not working properly, there is a decrease in the metabolism of exogenous insulin. This might lead to hypoglycemia. When your kidneys are not working properly, you are not reabsorbing glucose, you are not producing glucose, that might lead to hypoglycemia. Malnutrition in kidney disease, you don't have glycogen reserve, leads to hypoglycemia. A lot of patients with advanced kidney disease also have autonomic neuropathy. So the counter-regulatory response is not up to the mark. There is hypoglycemic unawareness. So there are a lot of factors in kidney disease which on its own predispose to hypoglycemia. And when you're giving insulin from outside, they predispose to hypoglycemia as well. But the story doesn't end here. What makes insulin therapy in patients with diabetic kidney disease a tightrope is that, just like there are factors which could lead to hypoglycemia, there are factors which could lead to hyperglycemia as well. Insulin resistance is significantly increased in patients with kidney disease. And if insulin doesn't work well because of insulin resistance, that could lead to hyperglycemia. Uremic toxins, they cause insulin resistance. Metabolic acidosis causes insulin resistance. Increased parathormone levels, decreased vitamin D levels, anemia, all of these contribute to insulin resistance in patients with kidney disease. Interestingly, these same factors also inhibit insulin secretion from the beta cell. Whatever little beta cell insulin is there is also inhibited by acidosis, by uremia, by increased parathyroid hormone, and by anemia. So these are factors which contribute to hyperglycemia in patients with kidney disease. So you have factors which could lead to both hypoglycemia as well as hyperglycemia in kidney disease, complicating the situation. Now we all know that if you have poor glucose control, it leads to microvascular complications, leads to further worsening of kidney disease. So bad glucose control, your kidney disease increases. But again, this is not a one-way traffic. Interestingly, hypoglycemia or lowering of blood glucose, severe hypoglycemia, can worsen kidney disease as well. So just like hyperglycemia can worsen kidney disease, severe hypoglycemia is known to increase macrovascular complications like heart attack, stroke, and also microvascular complications like kidney disease. So if you continue having severe hypoglycemic episodes, your creatinine might increase even further, your eGFR might go down even further. So the tightrope that we have to walk while managing kidney disease is avoiding hyperglycemia so that the patient doesn't have worsening of kidney disease, and avoiding severe hypoglycemia as well, because even that could lead to worsening of kidney disease. So if you look at the management proper in patients with early kidney disease, and in the early stages of kidney disease, classically usually patients have albuminuria, while the eGFR is more or less normal because of hyperfiltration. So your creatinine might be 1, 1.1 with the eGFR of 80, 90, but albuminuria is already there. And in this setting, it is mostly insulin resistance which predominates rather than having hypoglycemia. These are the patients who tend to have more hyperglycemia and need higher insulin doses. Now, there was a trial called the BARI 2D trial, which had two arms. In one arm, patients were either given insulin or sulfonylurea. In the other arm, patients were given either metformin or pioglitazone. It was found that in the arm where you give insulin or sulfonylurea, the insulin provider, the provision group, you had lower albuminuria with same glucose control compared to the insulin sensitization group, implying that providing insulin could have a protective effect at the level of the kidneys, but again, this was a subgroup analysis. Similarly, it has been found that patients on insulin pump who have lower glucose variability compared to those on basal bolus insulin have better albuminuria outcomes compared to those on basal bolus insulin. So lowering glycemic variability, providing insulin might have a protective effect in early kidney disease where albuminuria is predominant, but in these situations you might need a slightly higher dose because insulin resistance is very prominent there. And there's a biphasic insulin requirement, which means that early in kidney disease, you might need higher doses of insulin, but as kidney disease progresses, as a rule of thumb, your insulin requirement might come down. If your estimated GFR is say between 10 to 50, moderate to severe kidney disease, your insulin requirement can come down by about 25%. In more severe forms of kidney disease, it can come down by as much as half, as much as 50%. But again, the same rule doesn't apply to everyone. In certain patients, even with very advanced kidney disease, because of metabolic acidosis, hyperparathyroidism, anemia, you could have significant insulin resistance and require very high insulin doses. On the other hand, if you can reduce this, for example, on the day of hemodialysis, as metabolic acidosis comes down, uremia comes down, the dose of insulin has to be reduced as a rule of thumb by at least 1/4, if not more. Similarly, when you're using erythropoietin to correct anemia, when you're giving iron supplements to correct anemia in kidney disease, when you are giving calcitriol to reduce parathormone levels in kidney disease, the insulin requirement can come down as well. So it's a tightrope. There are factors which can increase, there are factors which can decrease. Peritoneal dialysis, particularly if it's a glucose-containing dialysate, can lead to an increase in blood glucose levels. You have to be careful there. Although most of the modern peritoneal dialysates do not contain glucose. So again, it has to be individualized. Early on, mostly increased requirement. As kidney disease progresses, the insulin requirement comes down, but there are exceptions where higher doses might be necessary, and as you start treating kidney disease through its various comorbidities, the dose requirement comes down. So it has to be individualized on a case-to-case basis. So I'll quickly take you through the pharmacology of different insulins in kidney disease and some studies which have been done with it. But to cut a very long story short, you can look at this trial which in hospitalized patients with kidney disease did a very simple thing. All these patients were on basal bolus insulin but were experiencing frequent hypoglycemia. They simply reduced the dose of insulin by 50% and found that glucose control remained the same, but hypoglycemia went away. So in your patients with kidney disease who are on a certain dose of insulin experiencing frequent hypoglycemia, you can consider reducing the dose, if not by 50%, by say 25%, and mostly you will get similar glucose control without increasing or rather decreasing the risk of hypoglycemia. But again, this is sort of a generalized empiric statement. We need individualization, and to look at it, we'll quickly look at the pharmacology of insulin in CKD. Now in this slide, I've spoken of pharmacokinetics. It's not that important, but it's just to get an idea of how the body influences drug metabolism in patients with kidney disease. So it is what the body does to the drug, that is pharmacokinetics, and what the drug does to the body is pharmacodynamics. So if you look at pharmacokinetics, insulin glargine has not been studied in terms of its pharmacokinetics in kidney disease. The others which have been studied are aspart, lispro, degludec, where interestingly the pharmacokinetics doesn't go much change, but glulysin shows a alteration in pharmacokinetics in kidney disease, whereas with detemir also it's unchanged. But detemir is not available, so we'll not go much into detemir. The next question is, or the more important question as a clinician is, if we put together pharmacokinetics, pharmacodynamics and everything, what happens to the usual dose requirement in kidney disease? Do we need a higher dose for the same degree of glucose control with these individual insulins? Or do we need a lower dose for the same degree of insulin control with the same insulins? This is a study in type 1 diabetes with kidney disease, which is actually a good basis for doing a study because there is no endogenous insulin secretion in type 1 diabetes. So whatever insulin you are giving from outside, and you are having a good idea of the dose. And this looked at 3 different degrees of renal function: EGFR more than 90, EGFR of 60 to 90, and EGFR of less than 60. It didn't look at more severe kidney disease. So it was found that if you look at the dose of insulin glargine with lower EGFR, you need a decrease in dose. If you look at NPH insulin, the last bar of the left side, the last 3 bars, you don't need a decrease in dose. The central one is detemir. I'll not go into that because it's not available. So usually you might need a decrease of insulin glargine dose as EGFR goes down. The dose of NPH insulin doesn't need to be changed. If you look at the rapid-acting analogs, to the right, if you look at the right 3 images, the right 3 bars, the leftmost of the right 3 is insulin lispro. Lispro requires a dose reduction as the EGFR goes down. The central one is aspart, which does not require a dose reduction. The rightmost is human insulin, which requires a dose reduction. So aspart, no reduction. Lispro, glargine, regular human insulin, you need dose reductions. So with that, we now look at bigger studies, clinical studies which have looked at the safety and efficacy of long-acting insulin and rapid-acting insulin in patients with kidney disease. With glargine, there are studies from India, in fact from Calcutta, as well as other countries, which have shown that you can safely and effectively use it depending on the dose you need titration in patients with kidney disease. It's not that there's a concept amongst some of us that you can't use long-acting insulin in kidney disease, which is not right. If you need good control, you need a basal insulin, and you can similarly use glargine in kidney disease. Similarly, there are studies with U300 glargine in kidney disease, which have shown that it is safe and effective in kidney disease. So if you looked at the previous slide and this one, we are looking at drugs, comparing them versus placebo, and have found that both glargine and U300 glargine are safe and effective in kidney disease. But as humans, we love comparisons. What if we compare glargine with NPH in kidney disease? What if we compare U100 with 300? If we compare glargine with degludec in kidney disease? And there are in fact several studies which have compared these long-acting insulins in kidney disease. I won't confuse you by going through all of them individually, but the overarching message is that through these trials is that if you look at U100 glargine, U300 glargine, and degludec, in terms of hypoglycemia, possibly degludec is the best of the lot. It causes less hypoglycemia than U300 or U100 insulin. In terms of glucose control, U300 insulin and degludec are the best of the lot, and U300 insulin is better than U100 glargine. Similarly, there are several other studies as well where all of these have been compared, and if you look at, again, the overarching message is that in terms of glucose control, degludec and U300 glargine are right up there in patients with kidney disease. In terms of risk of hypoglycemia, degludec has an edge over the others in patients with kidney disease. So that is the long-acting insulin part in patients with kidney disease. What about the rapid-acting insulin part or the short-acting insulin part? So there are studies. In fact, there is this very interesting study which has been quoted several times in literature, where use of lisproinsulin has shown some improvement in renal function independent of glucose lowering in patients with kidney disease. And it has shown that when you are using lispro compared to regular insulin, there is a decrease in glomerular filtration pressure, which might improve outcomes in patients with kidney disease. The hypothesis is that because of its unique modification, lispro shows IGF-1 receptor antagonism. We know that insulin and IGF-1, they have a lot in common. And by antagonizing IGF-1 at the level of the kidneys, it improves the glomerular filtration rate and prevents deterioration of kidney disease. But this is something interesting. If you look at the other rapid-acting analogs with aspart, we have data that compared to regular human insulin, it reduces glycemic variability, it reduces the risk of hypoglycemia. So in my earlier talk, I said that in patients with type 2 diabetes, aspart or lispro doesn't have much advantage in terms of glucose lowering or hypoglycemia compared to regular human insulin, but this is an exception. If you have kidney disease, moderate to severe kidney disease, with lispro you can get certain added benefits. With aspart, there is lower risk of hypoglycemia and lower glycemic variability. With glulysin, although I believe it's not that popular, one study showed similar results compared to regular human insulin. However, another study where CGMS was done showed that if you used glulysin compared to regular human insulin, you had better post-breakfast control and better post-dinner control. However, the post-lunch control was similar. So this is something interesting which came out from these studies. So again, to cut a very long story short and to sum up as to how and which insulin to use in kidney disease, if you look at the basal insulin that you are going to use, again, dose needs individualization. Early on, you might need somewhat higher doses. As renal disease progresses, the dose requirement comes down. But when anemia, uremia, hyperparathyroidism, metabolic acidosis kicks in, the dose requirement goes up. And again, when you start treating this well, the dose requirement goes down. So it's a seesaw happening all throughout. You have to keep that in mind. In terms of the basal insulin, if you look at the overall evidence, degludec and U300 are more or less similar in terms of efficacy. Degludec has a slight edge in terms of causing lesser hypoglycemia, and both of these are better than U100 glargine or NPH insulin. And the important message is that in every patient, almost every patient with kidney disease, even in patients on dialysis, you need a long-acting insulin. The dose could be low, the dose could be high. But if you don't use a long-acting insulin, glucose control is going to be difficult. If you need a short-acting insulin, again, if you look at the data, with lispro, there could be some benefit in renal outcomes independent of glucose control. With aspart, you have lesser hypoglycemia, lesser glycemic variability compared to regular human insulin. And with glulysin, there could be some benefit as well. And unlike patients with good renal function in type 2 diabetes, where the analogs don't have significant advantages compared to human insulin, here the situation is different. Here the analogs are clearly better compared to regular human insulin. Another area where the analogs score in patients with kidney disease is that you can give them up to 15 to 20 minutes after the start of a meal. Now this is important because we know that in patients with kidney disease, appetite comes down and it must fluctuate. On the day of hemodialysis, their appetite goes up. On the day before hemodialysis, their appetite goes down. And depending on the amount of carbs that they are eating at a certain meal, you can give the insulin 15 to 20 minutes after the start of the meal, higher dose, lower dose, depending on the amount of carbs that the patient is eating. So as you have seen in patients with kidney disease, there's no hard and fast rule of using insulin. It's like walking a tightrope. And as it has been said that if you are walking a tightrope for a few minutes, you can walk pretty safely. But if you're walking a tightrope for hours and days at an end, accidents are bound to happen, and accidents will happen. Your patient might land up with hyperglycemia or hypoglycemia, but unless we sort of individualize and unless we learn from these accidents, we are not going to walk the tightrope successfully. Thank you for your hearing. This is a monsoon image from the city that I come from. It's not as beautiful as Bhopal, but it still has some patches of green. Thank you.
Yes, sir.
The patient with nephrotic syndrome presented with generalized swelling. So, did it require changing the needle length? Because if that patient is very difficult to inject because of the swelling.
So yes, if there's significant edema, because when we are injecting insulin, our aim is to put it into the subcutaneous layer. So you first have the epidermis, dermis, then you have the subcutaneous fat, and then you have the muscles. So the smallest needles that we are using are 4 mm. This is because if you look at studies across ethnicities, the skin thickness usually, the epidermis and dermis, they usually don't exceed 2.5 millimeter. So with 4 millimeter, you are almost always certain to reach the subcutaneous space, but you will never reach the muscle because they are far below. Now the situation you are talking of is significant edema. So again, it depends. If the edema is in the epidermis dermis, that might increase the distance to the subcutaneous space. If the edema is in the subcutaneous tissue, it's not much of a problem because the epidermis and dermis is free. So you have to do a good, in the abdomen, again, the chances of edema are low but not out of question. There might be edema. So we have to look for parietal edema, like we do using the stethoscope or a blunt object. And if there is significant parietal edema, and if you feel that your insulin is requiring very high doses, not working, then possibly you can use a 6 millimeter needle and see. We still have the 6 millimeter pen needles available, 4 and 6 millimeter. You can use the bigger needle.
Well, stethoscope, you'll have to apply it, and if there is an impression. Then
The parietal
definitely,
edema,
yeah.
the good old clinical medicine with the
That's good.
stethoscope.
That's great. Nice to listen that. Any more questions? Thank you, Soumik. Thank you. Thanks a lot.
Thank you.
Again, I invite Dr. D.C. Sharma, sir. Now the stage is yours, sir. Take your time.
So friends, again, another lecture of practical importance and a more common situation. Patient comes and says, sir, my blood glucose fasting is fine, 110, 120, but PP sugar to kabhi normal aati hi nahi hai. And this is a common situation in most of our type 2 patients. So postprandial blood glucose management is important. And I'm going to focus on why, especially in our context. Why Indians especially, we have high PP blood glucose, which prandial insulin, how to initiate, how to titrate, and then I'll share some of the cases. So friends, in our country, India, this question and this postprandial blood glucose is much more relevant because most of us eat simple carbohydrates. In fact, there have been studies like this starch study which shows that Indians consume a diet which comprises of more than 64% of carbohydrates. I think 64% is much less. we consume more than 3/4 calories as simple carbohydrates. Rice, chapati, this is staple diet, and most of even non-vegetarians, they routinely eat chapati, rice, and which constitutes more than 74% of calories, leading to high postprandial blood glucose levels. And these are the studies showing from various parts of country, south, east, west, central part. Across the country, we consume a lot of rice and wheat, leading to high plasma glucose. Now, when we talk about blood glucose levels, most of the studies compare the which have studied UKPDS or DCCT, which have which have correlated the glucose control with the complications. They correlate with the HbA1c levels. So we assess blood glucose levels by HbA1c. कि आपका HbA1c 7 है तो ठीक है, 6.5 है तो ठीक है, 7.58 है तो it is high. So we correlate glycemic levels with HbA1c, which is a commonly used parameter. It is important to understand that what contributes, whether fasting plasma glucose or postprandial blood glucose, how much is the contribution of fasting and how much is the contribution of PP blood glucose to your HbA1c result. And this is important. There have been nice studies in the Caucasian population and Indian population. Monier et al. Was the most quoted study. Monier की study है, in which in Caucasian population, what was shown that if you assess the contribution of fasting and PP blood glucose in the HbA1c level, more you are close to the target. कि अगर आपका HbA1c 7.2, 7.5 है और उसे आप नॉर्मल 6.5-7 पे लाना चाहते हो, then more focus on postprandial blood glucose levels. If HbA1c level is between 7.2 to say 8.5, 50-50 contribution of fasting and PP blood glucose. But if HbA1c is more than 8.5, more likely that your fasting plasma glucose is contributing more to your HbA1c level. यानी अगर आपको HbA1c level को target पे लाना है, and if your HbA1c is around 7.5, focus on PP blood glucose. PP blood sugar को ठीक कर दो, आपका HbA1c level ठीक आ जाएगा. But if it's around 8.5 and 9, focus on fasting. Now this is a study in Caucasian population. In Indian population, where PP blood glucose is almost always high, irrespective of your HbA1c level, what has been shown here is across the HbA1c spectrum, whether your HbA1c is near target, that is around 7.5, 8, 8.5 or grossly high. Your PP blood glucose on the left side is Indian studies. You can see here. Your PP blood glucose are always high as compared to Caucasian population, whether your HbA1c is 9.8 or your HbA1c is 8.2, suggesting that if you focus specifically on postprandial blood glucose, अगर आप PP blood glucose ठीक करोगे, there are higher chances that you will achieve the targeted blood glucose values, HbA1c values of 6.5, 7 or 7.2. So targeting PP blood glucose to achieve the targeted HbA1c is more important in our context or Indian context. Now, why PP blood glucose is important? Because in general, higher the HbA1c or higher the blood glucose, hyperglycemia, prolonged hyperglycemia predisposes you to long-term micro and macrovascular complications. This is a well-established fact we learned from DCCT, UKPDS, Kumamoto, and many more studies. But PP blood glucose has specifically been correlated with long-term complications, both microvascular complication, but more importantly, macrovascular complication, such that high PP blood glucose has been recognized as one of the important cardiovascular risk marker. अगर आपका PP blood glucose higher है, that there are higher chances of your having cardiovascular disease. And the basis of this high PP blood glucose contributing to higher CV risk is multifold, maybe because of more inflammatory markers, more oxidative stress, and it has been nicely studies, correlating PP blood glucose with carotid intima media thickness. Higher PP blood glucose, more carotid intima media thickness, suggesting more atherosclerotic cardiovascular disease, more diastolic dysfunction, abnormal cardiac chamber volume correlated with PP blood glucose. PP blood glucose has also been correlated with some sorts of cancer. So PP blood glucose control and targeting PP blood glucose control is important in our population. Again, this diagram showing that if you target PP blood glucose, you are more likely to achieve the targeted HbA1c levels. To control postprandial blood glucose, you have several options. Amongst the oral tablets, we have alpha glucosidase inhibitors like acarbose, voglibose, even even DPP4 inhibitors. They are good for PP control as well. But amongst insulin, it is short-acting insulin. Shomik showed us, various types of short-acting insulin. We have regular insulin. We have analog insulin. Just to revise and recapitulate and repeat, what is the difference between short-acting insulin and the short-acting analogs? The shorter-acting regular insulin has got, gets absorbed quickly, but has their effect for more than up to 6 to 8 hours. While analog insulins have their duration of action up to 4 to 5 hours. Their onset of action is fast, their peak action is early, and the action is shorter lasting as compared to regular insulin. So the advantages of rapid-acting insulin is, before I discuss this, let me remind you and let me share with you the normal physiological insulin secretion postprandially. When we start eating, there is a first phase insulin response, and immediately the insulin tends to rise, such that within minutes the insulin action comes, and since the peak blood glucose levels comes at 30 to 40 minutes, 30-40 मिनट बाद हमारा खाने के बाद maximum blood glucose levels आ जाता है 30-40-50 मिनट में. At this time the insulin levels are highest. At 2 hours, most of the insulin levels have come down, at the basal level. 2-3 घंटे वापस आपका insulin level normal आ जाता है. If you use the shorter acting insulin, regular insulin, the effect would come after 20 to 30 or 40 minutes, even up to 50 minutes after injection. The peak effect will come, say 30 to 60, not 30 minutes, 60 to 90 minutes later, when your postprandial blood glucose is already spiked. Now the insulin has come into action, and the effect will be prolonged for 6 to 8 hours when you no more require insulin. Result is that your PP blood glucose remains higher, and you have more often postprandial hyperglycemia 3 to 4 hours after taking meals. And in order to compensate that, you need to eat snacks 3 to 4 hours after taking insulin, so that blood glucose swings are there and you keep putting on weight. The advantage of rapid acting insulin analogs is that you have faster onset of action. It more closely mimics physiological insulin secretion. The higher peak insulin concentration around high PP blood glucose, it matches the postprandial blood glucose peak values. It improves better PP blood glucose and overall HbA1c, less weight gain because the compensatory snacking is less required with analog insulin, and lesser rate of hypoglycemia, lower weight gain, and better blood glucose control. Currently, there are 3 types of shorter acting analogs. Shomik again showed this picture: Lispro, Aspart, and Globalizin. There are minor differences in the pharmacokinetics of these agents. Say, for example, Lispro has the fastest onset of action. You have immediately, within minutes, 5 to 15 minutes, you have onset of action. The peak is early, and the duration is relatively shorter as compared to the other insulin. So Lispro is better. Minor differences, but these differences are there. Now, when you start injecting, it is based on the individual, body weight. The dose needs to be as per the body weight, and there is a system of titration also. So, initiating prandial insulin, if PP blood glucose is high, the dose required would be 10% of the basal dose. If somebody is using 30 units of basal insulin, 30 units glargine ले रहे हैं, तो 3 units. Or roughly 3 to 4 units will not cause hypoglycemia. So 10% of the basal dose, and then titrate it based on the postprandial blood glucose levels, as I mentioned earlier also. If PP blood glucose is high, or the next meal blood glucose is above 160 or 180, up titrate the bolus dose by 1 to 2 units every second or third day till you have postprandial blood glucose in the range of 180 milligram per deciliter. So this is RSHDI guideline again saying that initiate the prandial insulin start with 4 units and increase by 1 unit per day or 2 to 3 units every third day till your PP blood glucose is less than 180. Then if required, you give basal insulin, bolus insulin with one meal. Then after months, you might require bolus insulin with another meal. And finally, most of the patient would require basal bolus insulin, say type 2 patients of 7 or 8 or 10 years duration. They will be on basal bolus insulin if you really want them to be having good glucose control. Now, titration is important, as I mentioned earlier. Titration is the key to success. And titration is for fasting plasma glucose, for basal insulin. FBG, fasting plasma glucose, gives you an idea about how much basal insulin needs to be changed. And post-meal and next pre-meal insulin blood glucose levels would give you an idea about the dose titration for the short-acting insulin or the prendial insulin. There's a lot of repetition. So Lispro again is available in 2 strength, 100 units and 200 units. If the prendial dose of insulin is higher, say 10 to 15 units of insulin is required with each meal, to minimize the injection site comfort or injection site pain, you can use more concentrated insulin, that is U200. Otherwise, U100 and U200 is available. There is no other difference in the pharmacokinetics. Now, junior quick pen is also available. If you are familiar in treating type 1 children, we have got so many type 1 children, and in say 2-3 years of age, some of them require 1.5 units. With 2 units, they have hypoglycemia. With 1 unit, they have hyperglycemia. So you require 1.5 units before meal. So for these children to titrate the doses by 0.5 units, junior quick pen is also available. So here are a case studies again highlighting almost same things which I have mentioned, but just to again emphasize the faster acting insulin. The peak is early, shorter duration of action, early peak, and better mimicking the physiological insulin secretion as compared to regular insulin. Less hypoglycemia with the analog insulin as compared to regular insulin. So to conclude, traditional Indian diets are carbohydrate rich. Across HbA1c targets, the PP blood glucose contribution remains high in Indian population because of high consumption of simple carbohydrates. Compared to regular human insulin, the rapid acting insulin analogs are better in terms of faster absorption after SC administration. Peak plasma concentration of rapid acting analogs is approximately double. Time to maximum concentration is again shorter. Choice of perennial insulin should be tailored as per the patient's requirement. Lispro is available in 100 units, 200 units, and as a junior quick pen with 0.5 unit titration advantage. Thank you.
Thank you. Thanks a lot, sir. Now the house is open for questions.
15 to 20 minutes walking after every meal. Does it affect postpartum blood glucose level?
Walking 30 minutes after meal.
15 to 20 minutes
Yeah.
low pace walking after every meal. Does it affect postpartum blood sugar?
I think yes, because there are several advantages. If you sleep immediately after meal and if you become sedentary, your system goes low. And walking would definitely help you in achieving better blood glucose levels. So in general, walking anytime would be better, but especially post meal. Once because sedentary, or if you especially sleep post prendially, दिन में खा के सो गए, तो आपका system भी सो जाएगा. And you will have more gastric hypokinesia, more GI symptoms, and more PP blood glucose, higher blood glucose values.
Sir, how do you rate ripaglinide for PP blood glucose control?
Yeah, ripaglinide is not sulfonylurea, but it acts like sulfonylurea, and This is you can say it is a short-acting sulfonylurea-like preparation. It better controls postprandial blood glucose. It's a wonderful drug for better for postprandial blood glucose levels, but then there are several limitations. It acts like sulfonylurea. It acts as long as you have beta cell function. So this doesn't work in those who have exhausted their beta cells, जिन्हें बहुत लंबे टाइम से डायबिटीज़ है, बहुत ज़्यादा हाइपरग्लाइसीमिया. This reminds me of several examples we come across. Prescriptions की 4 मिलीग्राम ग्लिमेपेराइड चल रहा है, 3 ग्राम मेटफॉर्मिन चल रहा है, और PP blood glucose 200 है. Now you are expecting ripaglinide to work on PP blood glucose? Unlikely. So when the beta cells are exhausted with the long-term, with the chronic hyperglycemia, long duration of diabetes, or patient is receiving multiple dose drugs in the optimum doses, ripaglinide is not going to act. It's a good drug for those who have shorter duration of diabetes, mild diabetes, to better control PP blood glucose.
Thank you. Thanks a lot, sir. It was a good lecture. I take the opportunity because we have got 2 erudite speakers with us. Okay. So Amit is asking कि I should continue with the lectures only. So it's my job now to end the section with this. Okay. So we have talked about kidneys, we have talked about in-hospital insulin therapy, we have talked about so many other things. But liver is something which is less talked of when it comes to insulin therapy. And I was searching the reviews also, there are less reviews, less reviewed. And हम बोलते हैं अरे ठीक है cirrhosis है, कुछ नहीं होता, लगाओ insulin. This is what we used to have. We used to worry a lot about kidney involvement. But when it used to come to liver, बहुत ज़्यादा हमारा attitude ऐसे ही रहता था. So let's see how the story of liver unfolds. Why does the same insulin dose work perfectly in one patient but cause severe hypoglycemia in other with cirrhosis? This is a question. Why this topic is important? Because MSLD affects nearly 1/3 of our adults worldwide. 80% of my diabetic patients, they have MSLD. I request you should also do at least the FIB-4 scoring in your clinical settings. FibroScan is not required, but FIB-4 index can help you in screening out these patients. I have started. You should also think of starting it. Approximately 70% of the patients with type 2 diabetes have MSLD. And diabetes doubles the risk of cirrhosis. Cirrhosis significantly increases the risk of hypoglycemia, and liver disease changes insulin metabolism, making standard dosing unreliable. This is how Soumik was telling us regarding kidney. So the story is not that different when it comes to liver involvement. So the liver is the metabolic control center. It is responsible for glycogen storage, glucose production, fat metabolism, protein synthesis, insulin degradation, and ketogenesis also. So the liver is a major determinant of insulin action. About 50 to 80% of endogenous insulin is extracted by the liver during its first pass through the portal circulation. The liver suppresses hepatic glucose production in response to insulin. It stores glucose as glycogen after meals and releases glucose during fasting. So it acts as a barrier for hypoglycemia. It degrades insulin through insulin receptors and insulin degrading enzyme, limiting systemic insulin exposure. So healthy liver regulates both how much glucose enters the circulation and how long insulin remains active. The second part is just like kidney to some extent, not to a larger extent. So liver as a central banker, अब आप ये कहें तो during meals it deposits glucose, during fasting it withdraws glucose. बैंकर का काम ऐसे ही होता है ना. Insulin tells the liver store glucose. अगर insulin नहीं है तो glucagon will tell the liver release the glucose to prevent hypoglycemia. So now what happens is if the banker becomes sick, अब SBI में लॉक लग गया, छुट्टी हो जाती 2-3 दिन में, तो we are in great difficulty. I don't know why they do so many holidays are being given to these banks. मुझे लगता है संडेज को भी they should work because the kind of life we have, बैंकर के बगैर तो चलता ही नहीं. So the normal hepatic insulin signaling is like this: कि insulin will act on the insulin receptor, the IRS1 or the sub-receptor part, IRS2, then PI3 kinase pathway will get activated, then AK3 will act, then it will reduce to decrease in gluconeogenesis. It will increase glycogen synthesis, storage cassettes आपके energy cassette store करेगा. Decrease glycogenolysis also, because there is enough, it's a state of abundance, तो glycogenolysis की ज़रूरत नहीं है. And normal glucose production. The liver produces the glucose, but it is normal when everything is normal in liver. What happens? The mechanism of insulin resistance, what happens with the liver failure? Obesity होता है तो increase, there is increase in free fat. I think I missed one slide. Okay, no, it is like this only. So obesity will lead to increase in free fatty acids to the hepatocytes. There will be a gush of free fatty acids. Will again increase diacylglycerol, PKC activation, and decrease in insulin receptor signaling. Decrease in IRS1, IRS2, the same pathway, PI3, AKT, insulin resistance. Now, just because of this pathology, the same liver is producing more glucose. तो आपका fasting hyperglycemia हो जाएगा. The pathophysiology of the mechanism, the same thing has been depicted in this cartoon, reflecting the cycle among hepatic steatosis, insulin resistance, and hyperinsulinemia. So I think, no, this is not the right one. So this is how it is, because just because of more of insulin clearance, more of the fat deposition of the liver, there will be more of lipolysis, more of generation of the other factors, which will lead to MFLD. It will increase the liver fat content, hepatitis, hepatic fibrosis, gluconeogenesis will go up, and the blood glucose will also go up. This will create decreased insulin sensitivity, and pancreas will end up making more and more copious amount of insulin. This is what happens in insulin resistance. खूब सारा insulin बनता है एक particular sugar level पे. When you have insulin resistance, the amount of insulin secreted is more. It is phenomenally high, and that is increasing the beta cell load. And definitely, the beta cells are about to underperform, and they will not meet the requirement. And once the requirement of insulin is not met, the sugars will go up. This is how the scenario is. Let's come to a case. A 45-year-old man, BMI is 34, HbA1c is 9.4, ALT is 82, grade 2 fatty liver, hyperinsulinemia. Fasting insulin is 190 milligram per deciliter. Why is his fasting? It is not fasting, it is fasting glucose. So why his fasting glucose is 190 milligram per deciliter despite hyperinsulinemia? Insulin levels are high, but still the glucose is 190. This is a misspelled over here. So why is it so? Let's see. Because hepatic insulin resistance prevents insulin from suppressing gluconeogenesis. So the liver continues to produce glucose despite already elevated insulin levels. This is what is happening when the liver is, the banker is suffering. So the stages of liver disease, early liver disease, MSLD, MASH, insulin resistance predominates. What happens? Excess triglycerides accumulates in hepatocytes. Lipotoxic intermediates like diacylglycerol, activated PKC, impairing insulin signaling. Hepatic glucose production is no longer adequately suppressed. Chronic inflammation, TNF-alpha, IL-6, and oxidative stress further worsen insulin resistance, and the pancreas, it is something which sympathizes with liver, and it compensates by more and more of insulin. This is how the mechanism, the interplay of insulin, liver, and pancreas is there. This is altogether a different cycle which works when the liver is also involved. So the clinical consequences of early liver disease, that is MSLD, is persistent hyperglycemia, higher exogenous insulin requirements if insulin is initiated, and hyperinsulinemia. The three triangles, they are actually contributing when it comes to liver involvement. Which insulin in MSLD, early MSH? If HbA1c remains uncontrolled despite oral agents or incretins, basal insulin is appropriate. Preferred is insulin degludec, insulin glargine U300, and insulin glargine 100. Why? Because lower hypoglycemia, predictable pharmacokinetics, once daily dosing, continue GLP-1 receptor analog when appropriate. So you did not stop these molecules. And over the top of it, a basal insulin will help you. Whenever we are struggling with fasting hyperglycemia, definitely we give a shot of basal insulin. Progressive fibrosis is a transition phase. Now the fibrosis is trying to set in because it is MSLD is leading towards MSSH. Functional hepatocyte mass begins to decline and hepatic insulin clearance decreases. Now the insulin clearance is also decreasing. Portal hypertension may develop, causing portosystemic shunting, and insulin resistance is still present, but insulin remains in the circulation longer. It is getting lesser and lesser metabolized. So like kidneys, the insulin, the involvement, like kidney involvement, in the liver involvement also, you tend to have more hypos. So which insulin and fibrosis now? Insulin resistance remains significant again. The preferred is basal analog, prandial analog if required, because the chances of hypoglycemia is there. Monitor carefully because insulin clearance may begin to decline. A 55-year-old male uses glargine 28 units, no dose change, HbA1c is improving. Suddenly develops repeated nocturnal hypoglycemias. Is on glargine but now having nocturnal hypoglycemia. Which factor is most responsible? It is better compliance, weight loss, reduced hepatic insulin clearance, or exercise. Reduced hepatic insulin clearance is something which can lead to hypoglycemias and nocturnal hypoglycemias. Cirrhosis now, after fibrosis, definitely the thing which will come in is cirrhosis. Reduced insulin clearance becomes dominant now. Gradually it was getting reduced. So loss of functioning hepatocyte reduces insulin metabolism. Portal systemic shunting allows insulin to bypass the liver. More insulin reaches the systemic circulation, and the biological effect of each insulin dose is prolonged. At the same time, hepatic glycogen stores are depleted. Gluconeogenesis is impaired. Counter-regulatory response are blunted. What are the counter-regulatory response like glucagon, like cortisol, like catecholamines? These are the counter-regulatory modes. And the malnutrition and sarcopenia reduce glucose reserves. So the clinical consequences markedly increased risk of hypoglycemia, greater glucose variability, and lower insulin dose requirements in many patients. So which insulin is in compensated cirrhosis, that is child PUG-A classified group? Preferred regime is basal analog. Add rapid analog only if necessary. Avoid aggressive titration. Suggested starting dose is approximately 20 to 25% lower than in patient without cirrhosis. Then titrate according to self-monitoring of blood glucose or CGM device and nutritional intake. So which insulin in decompensated cirrhosis? Now we are talking about child B and C. Insulin is usually the safest glucose lowering therapy because many non-insulin drugs become unsuitable or require caution. The preferred is basal analog or rapid acting analog. Avoid premixed insulin whenever possible because they tend to make scene of hypoglycemia more. Why? Meals are unpredictable. Fasting is common, hospital admissions are frequent, dose flexibility is essential, and analog insulins are generally preferred because of lower risk of hypos. Which basal insulin in liver disease? Definitely the preferred one we are talking about, just like kidney, which Somik showed. The slide is same, almost a photocopy of it. So degludec and glargine is something which stands tall when it comes to such kind of tricky cases. Which preferred insulin in liver disease? Preferred is aspart, lispro because they are analogs, they are shorter acting, the faster aspart and glulysin. Advantage is better postprandial control, less delayed hypoglycemia, greater flexibility with meal timing. Regular insulin can be used when cost is a concern. Requires meal planning and carries a greater risk of late hypoglycemia, as Sir was talking about. The shorter acting insulin, the effect goes fast. But the longer acting insulin, it may last for 4 to 6 hours. So when the tummy is not full, it is all emptied, all of a sudden you may have an episode of hypoglycemia. This is what the slide is telling us. Should prefixed insulin be used 30-70? In MSLD may be acceptable if meal timing is consistent. In cirrhosis, generally you should avoid it. Reasons: variable appetite, because of the patient is seriously ill, malnutrition, hepatic encephalopathy, frequent fasting, increased hypoglycemia risk, and basal bolus therapy provides greater flexibility. So if the patient is in a state of cirrhosis, try to avoid this 30-70 kind of thing. There are multiple genuine answers for it. The practical dose adjustment, MSLD, standard initiation titrated according to glucose, fibrosis, standard or slightly reduced dose if concern for reduced clearance. Child pug A, start 20 to 25% lower than usual. Child pug B and C, individualized, many patients require substantial dose reduction, often by 30 to 50%. We are not staging our patients sometimes just because of the time constraints in clinical practice. But this is how the responsibility goes up if you are going more near towards the theory and text. This is a problem. But this is what the younger generation should get in, because this is how you can make difference in your practice. Acute infection, the requirements may temporarily increase, and poor oral intake and fasting reduce or withhold prandial insulin and reassess basal dose. The percentage are expert opinion starting point rather than the evidence-based fixed rules, and should always be individualized. This is something, a kind of disclaimer. So prescribing insulin for diabetics, mellitus and cirrhosis, insulin therapy, stable patient with cirrhosis, ketoacidosis, definitely insulin infusion. Blood sugar less than 300 per deciliter, no acute event, oral drugs can. Poor controls, go for insulin. If the blood sugar is greater than 300, go for insulin, straight away go for insulin. Acute event, bleeding and encephalopathy, sepsis, these are major complications which we come across. Please give insulin. Start with basal insulin. Initiation basal analog at a dose of 8 to 10 international units or 0.1 to 0.2 units per kg body weight. And the fasting plasma glucose is 90 to 150. If FPG is more, increase by 2 units every 3 days. And if FPG is less than 90, you'll have to cut down the doses to prevent hypoglycemia. Intensity, again, prandial control if the postprandial is also more. If PPG is greater despite basal insulin or basal dose greater than 0.5 units international per kg, initiation is mealtime regular insulin, the rapid acting analog at 4 international units or 10% of the basal insulin. The 10% of the basal insulin for beginners, they can give it as a prandial doses. And titration increased by 1 to 2 international units or by 10 to 15% every 3 days if greater increase in PPG or neopremeal glucose. But if you are facing, again, sometimes we don't follow this algorithm, but then you need expertise and person who is well versed with insulin therapy, he can go for further escalations. Algorithm of managing diabetes in cirrhosis. Again, the management of diabetes in cirrhosis, the fasting glucose sugar may be lower in cirrhotics. HbA1c may be unreliable in cirrhosis. The lifestyle interventions like calorie, protein, frequent meals with high protein breakfast and energy-rich late evening snacking. Calorie deficit for obesity 500 to 1000 kilocalories per day. That is saying, then pharmacotherapy, stable patient, no acute event of blood sugar is less than 300 and HbA1c levels are less than 10. Non-insulin based initial therapy, continue low dose metformin, watch for hypoglycemia, obesity, renal dysfunction and encephalopathy, and accordingly you have multiple options. But acute severe event is there, sepsis, bleeding and encephalopathy, then definitely you should start insulin. So this is how the algorithm of management of diabetes with cirrhosis goes. The patient who needed more insulin before, he needed less. Now this is an enigma. A male patient, age 45 years, MSLD, HbA1c is 10%, started glargine 28 units. After 2 years, needed 48 units. 5 years later, developed cirrhosis. Same insulin, but suddenly develops repeated nocturnal hypoglycemias. ऐसा बहुत होता है क्लिनिकल प्रैक्टिस में कि भाई 28 यूनिट्स है, हमने बढ़ा दिया 48 पे, बढ़िया चल रहा है, ऑल ऑफ अ सडन बोले डॉक्टर साहब 3 साल तो अच्छा चला, अब शुगर लो हो रहा है. तो डेफिनेटली वी शुड सी for the development of cirrhosis, same insulin, but suddenly developing hypoglycemia. What changed? Not the insulin, not the pancreas. These two things are almost the same. It is the liver which has changed. The therapeutic drugs associated with hepatic lipid accumulation induce type 2 diabetes and their targets. This is just for the information, like DP4 inhibitors, thiazolidinediones, metformin, ACC inhibitors, or maybe FXR agonists. These are the things which are in pipeline, GLP analogs and SGLT2 inhibitors. The management of diabetes and liver disease requires an understanding of changing pathophysiology rather than fixed insulin doses. As liver disease progresses, insulin therapy must evolve from overcoming insulin resistance to preventing hypoglycemia. A patient-centered, stage-specific approach with careful monitoring is essential to achieve safe and effective glycemic control. So the key takeaways are the liver plays a pivotal role in insulin metabolism and glucose homeostasis. Early MSLD insulin resistance will lead higher insulin requirements. Advanced cirrhosis, reduced insulin clearance, lower insulin requirements, and higher hypoglycemic risk. Assess liver disease severity, use child per classification, assess for nutrition, assess for renal function before choosing insulin. Basal insulin analogs are generally preferred. Avoid premixed insulin in advanced cirrhosis. HbA1c may be unreliable in cirrhosis. Use SMBG, CGM for treatment decisions. Start low, titrate slow, monitor frequently to minimize hypoglycemia. Individualize insulin therapy according to the stages of liver disease and the patient's clinical status. Thank you. Thanks a lot. Amit, change kar do. So this is how the therapy is. I will take only 5 more minutes. How many of you know that tirzepatide is available in 2 names in India? I'm just talking from the point of the sponsors. So whenever I write tirzepatide, the people say it should be Mounjaro. But there is one more drug which is available in the name of Yorpic, marketed by Cipla. तो मुझे just requested कि आप मुझे 5 मिनट दीजिए, तो मैंने कहा चलो ठीक है. Mounjaro, semaglutide, the patented one, the non-patented one, these are the 3 arms, and one is Orlistat. So in clinical practice, we are comparing all these 4 arms, and there are a good number of patients who are in combination of Orlistat with Mounjaro, Orlistat with Yorpic, Orlistat with semaglutide also. So when it comes to obesity management, what my experience is, what I'm seeing right now, though it might be anecdotal, I'm just waiting for our data to come. It is not like one prescription fits all for all. It is something which is much more than that. There are a good number of patients who are on very costly drugs, not losing weight, but when they restart, when they rethink over their daily lifestyle changes, that is very important, diet and exercise, they start losing weight. There are a good number of my patients. There are a good number of patients who are doing well with the oral drug. There are a good number of patients who are showing very good response when it comes to these kind of molecules. बहुत सारे पेशेंट्स होंगे आपके, तो जब भी आपको लिखें क्लिनिकल प्रैक्टिस में असेस करें कि इस साथ का एक्कम्पनिंग रिलेटिव कैसा है. इफ़ वो फिनिकी है, बहुत स्ट्रेस्ड आउट है, पेशेंट भी अगर बहुत स्ट्रेस्ड आउट है, फर्स्ट विजिट पे मत लिखिए ये मॉलिक्यूल, क्योंकि जब तक उनकी एंग्जाइटी सेटल नहीं होगी तो पता चला रात को ही फ़ोन आ गया, डॉक्टर साहब ये क्या दे दिया आपने, पेट में ऐसी इधर इतनी लंबी लंबी गैसेस चल रही हैं, पेट बहुत दुख रहा है, कुछ बोलेंगे डस्ट लग रहे हैं. They will not take their patient to hospital. They will straight away come to you कि आपने लिखा इसलिए हुआ. तो the drugs are very good, no doubt. The drugs are very good. They are a breakthrough kind of thing. But this is not a one solution in clinical practice. So use it rationally. It is a very good drug for diabetes control also. Whenever my insulin levels, they go beyond 70, 80, and still I'm struggling, I introduce one of these molecules, and the result is phenomenal. It is a drug which is very good for these kind of resistant diabetics. These diabetics who have underlying liver enlargement, liver involvement, MSLD. It is a very good drug. It is a drug which is offering not just sugar control, not just weight loss, it is taking care of your kidneys. Few days back, there was one gentleman who was not undergoing any kind of acute injury, but the creatinine levels were around 3. I might not have assessed the acute status. But after starting the medication, there are a good number of them. They are reducing with respect to microalbuminuria. Even the creatinine levels, though my experience is anecdotal, it is also going down. And patient को बड़ा अच्छा लगता है कि साहब मेरा 3 creatinine था, अब मेरा 1.5 ही रह गया. So such kind of things are also coming up with the molecules like tirzepatide. So the molecule is definitely a breakthrough. And in clinical practice, whenever you come across, you need to actually address this metabolic issues from all nooks and corners. जहाँ से hit करना hit करिए, rationally hit करिए, पर hard hit करिए. This is what the message is. And with that, I would like to conclude it. Thank you. Thanks a lot. No. So,
Sachin, one
yes, sir.
comment. Yeah. So wonderful meeting, and we discussed so many aspects of insulin therapy. But this pre-mixed insulin, the contraindication which Sachin showed, reminds me of highlighting this point here, because so many physicians sitting here. Please don't use pre-mixed insulin for children.
It's true.
We come across so many patients, so many children to whom we initiate with basal bolus insulin therapy. They are doing very well. And all of a sudden 8 महीने बाद आता कि साहब वो इंसुलिन, तो डॉक्टर साहब ने कहा कि ये उनको पता नहीं क्या कि 2 बार वाला इंसुलिन भी अवेलेबल है. And the child was switched over from basal bolus to premix insulin, and again child is having hyperglycemia. And many children, coming back to us after 8 to 10 years with advanced kidney disease, neuropathy, retinopathy, then we cannot help. So please don't use premixed insulin for children. Type 1, it's always basal bolus insulin therapy. Leaving aside very countable number of patients who in the very initial time of diagnosis, they may be controlled with basal bolus with premix, but ultimately they will require premix insulin. Similarly, Sachin showed liver disease, kidney disease, advanced kidney disease. Premix insulin is likely to lead to more fluctuations, more hypo and hyperglycemia, weight gain, and patient never controlled. So premix insulin, though we were when in our training period and for a very long period we had only premix insulin. हमारे पास एक ही कंपनी थी पहले, and they promoted premix insulin. Even our guidelines, they were biased. Let me tell you very frankly,
Yes, very
that most of the guidelines were forcing the premix insulin. Premix insulin से अच्छा है अपना basal insulin when required. So in type 2 diabetes, when you need to initiate insulin, basal insulin, and I think basal plus would be a better choice. In some patients, premix insulin in type 2 patients can be doing your blood glucose control. Otherwise, basal plus, or ultimately basal bolus. So we should also understand where not to use premix insulin in advanced kidney disease, renal disease, as Sachin showed, and also in type 1 children. Thank you.
Thank you, sir. Thanks a lot. Samit, do you want to add on something?
We have had a very good discussion.
No. We just want to hear more.
Covering all the facets.
Just creating that kind of
I
thing.
think there's a very good guideline. There is a group called FITT Fitter who bring out a guideline for insulin injection technique, storage.
Yes,
so there are a lot of images there, nice images. So if you go through that Fitter guidelines, it's a free download, FITTER guidelines for...
There's the Indian version also now.
Indian version for insulin storage, administration. Some of the common mistakes are dealt with there.
Yeah.
That will help in your practice.
We should
all
be
doctors
actually...
and all the nursing staffs,
Yeah,
I mean the
they
educators
should be
and
well equipped with
dietitians
that.
working with you,
True.
they should be taught the
Fit guidelines. Yeah. Whenever I read it sometimes, I find everything, every time I'm correcting myself. It is really worth reading. So rationality of diabetes treatment is something which is very important, and it should be given prime importance. And the first one, the hero of your clinic is your patient, the Amitabh Bachchan. He should be given a hit movie, not a flop one. Sometimes he lands up with hypoglycemia, and every time there are good number of my patients also who land up with hypoglycemia, but every time is a learning. So I take the opportunity to invite Dr. Prabhakar Tiwari sir to felicitate our dignitaries. Sir. Sarai. Dr. DC Sharma sir, please. Thanks, sir. Dr. Swami Goswami is from Calcutta, a very bright person. Thank you. A group photograph. So I respect all of, I request all of you, please come for the group photograph. Thank you. Thanks a lot for coming. It was a good show, and the way, the kind of interaction will have to keep on increasing. Let's keep the level high. Thank you, sir. Thanks a lot.